various aspects of the pregnant woman and help how to approach the life of the mother and child. Thank you so much for inviting me.
Thank you so much, Veena ma'am, for that words of blessings. Means a lot to all of us. And thank you for highlighting on the important aspects that we are going to discuss today. And I'm sure that the audience who are present over here will have a very, very enlightening session. Just to inform, thank you so much, ma'am. Just to inform all of you, we see in the participants list 16 members, but just to let you know that the 16 members that are there are only the faculties that are there, and we have a separate link for audience. So we have almost 150 plus delegates who have joined us as of now. So I just wanted to inform you that. So thank you so much once again. So now I would like to invite our guest of honor again, Dr. Abha Singh ma'am. Can I have ma'am's slide, please? Dr. Abha Singh ma'am, again, a patron, and she has been in the Raipur Obstetrics and Gynecological Society, associated with a lot of societies in the Chhattisgarh and in the MP region. She has been the vice president of the SOVSI, founder and present president of the AOGCG, and the patron of ROGS, past president of ROGS, IMS, and Raipur. She has been awarded a number of awards, including the Health Icon Award, the CM Trophy for Meritorious Service, and the Padma Shri S.K. Mukherjee Award. She has been the ex-dean of the Pandit JLN Medical College, Raipur as well, and an ex-vice chancellor and of the Deen Dayal University of Medical Sciences. Ma'am, it's a pleasure for me to welcome you. I still remember the day I came to your house and I met you, and it's still a fresh memories from the hospitality that you provided that day, ma'am. Thank you so much for being here. It's a pleasure always to invite you and talk to you. I request you to please tell a few words of blessings to everyone present over here.
Yes, I first of all begin by thanking you, Priyankur and Dr. Monica. And it's really a pleasure to join on this platform because the topics are excellent. And it is well established that during pregnancy, at any point of time, there may be complications. So the prevention, the timely recognition, the very basic and emergency obstetric healthcare means a lot. And we have very good and selected speakers on the selected topics. So I'm just waiting to hear from them. Thank you so much for the invite.
Thank you, Abha ma'am, for those words. Thank you. It means a lot that you have joined us and you shared your experiences and blessings with us. Thank you so much, ma'am. Now I hand over this session to Monica to kindly take us through the scientific session. And I would like to again welcome our speakers, esteemed speakers, Lakshmi ma'am and Dr. Gaurav for it. And of course, after that, we are going to have an enlightening panel as well. So over to you, Monica.
Thank you, Abha ma'am, and thank you, Veena Acharya madam, for joining us for the inauguration of the 21st episode today. We are now going forward with the scientific session, which is the first talk by none other than Dr. Lakshmi Srikhande madam on respectful maternity care. I would welcome our chairpersons, Dr. Rashmi Kahar and Dr. Deepa Masand for the same. Can we have the CV slides, please? Dr. Rashmi Kahar madam is currently the president of the Amravati OBGYN Society, and she is the chairperson of the High Risk Pregnancy Committee, AMOX. We welcome you, ma'am. Our next chairperson is Dr. Deepa Masand madam. She is a senior professor and head of the unit at the JNMU College, Jaipur. She is also the president Narchi of the Rajasthan state, the president-elect of Jaipur OBGYN Society, and she is a part of the managing committee member of the Jaipur Menopause Society. We welcome you, ma'am, to please share this session and introduce Dr. Lakshmi Srikhande madam. Priyankur, can you just introduce Rashmi ma'am? She was there. I could see her, but now at present she's not there.
Monica?
I think Rashmi madam has got disconnected. I'll just call her back. In the meantime, can you please introduce Lakshmi ma'am?
Of course. It's always a pleasure and honor to introduce always smiling and always helpful person, Dr. Lakshmi Srikhande ma'am. We experienced wonders when she was the ICOG chair, and of course, she's always there to help us in whatever we need. She's the immediate past chair of the ICOG. She's the national corresponding editor of Jogi, national corresponding secretary of the AMWI, president of ISOPAR, and also the chairperson also the chairperson of the IMS Education Committee. Ma'am has been the chairperson of the Fertility Enhancement Committee of ISOPAP as well. She has a number of publications, and as I said, a knowledgeable person, always ready to share her knowledge and experience to everyone whenever you are in trouble. I welcome you, ma'am, and request you for your talk. I'm sure it's going to enlighten.
Thank you. Thank you so much, Priyankur. I know you are doing wonderful job as the PSC committee chairperson. I wish you all the very best. Please stop screen share so that I can start my sharing. Priyankur,
Thank you
all
so
the
much, ma'am.
best for your all the future endeavors. And I must say that you are very lucky and blessed to have Monica Umbardan as your coordinator. That girl is simply too sincere, and really she coordinates very well and doing fantastic work. Monica, hats off to you.
Thank you,
Absolutely,
sir.
it is.
Thank you so much, ma'am.
Yes, for your all the hard work and dedication towards all the activities. So friends, today my topic is respectful maternity care. So first and foremost, we should know what is respectful maternity care. This is a universal human right that is due to every childbearing woman in every health system around the world. It includes respect for women's autonomy, dignity, feelings, privacy, choices, freedom from ill treatment, and coercion and consideration for personal preferences, including option for companionship during the maternity care. So RMC is an attitude that permeates each word, action, thought, and non-verbal communication involved in the care of women during pregnancy and childbirth. So it is effective communication, positive attitude, respect for patients, caregivers, and staff. It is both ways, and an environment which is conducive to the care and recovery. So far, what we know about the disrespect and abuse in childbirth. We know that this is a global problem. It occurs in low, medium, and high income countries. There are many anecdotal reports, but there is very little formal research on this. There are no standards for respectful care. And remember, disrespect and abuse is a violation of human rights. So the 7 domains of disrespect and abuse are physical abuse, non-dignified care, non-consented care, non-confidential care, discrimination, abandonment or withholding of care, and detention in facilities. So what do I mean by physical abuse? That this lady has the freedom from harm and ill treatment. The second component is non-consented care, that is, woman has right to information. She should be informed. There should be informed consent. She can refuse. You have to respect her choices and preferences, including companionship during maternity care. It is her right to have a confidential care. About the fourth component, it is her right to have a dignity, respect, privacy, and confidentiality during childbirth. About the fifth component, she has the right for equality, freedom from discrimination, and equitable care. She has a right to timely health care and to the highest attainable level of health. As far as detention in facilities is concerned, she has right to liberty, autonomy, self-determination, and freedom. You just can't detain her in any facilities for non-payment of bills. So when it comes to treating women with dignity and respect, what can you do? You can inform the patient and her relatives about the examination findings, about your treatment plan, and you have to involve them in the decision process. Remember, you not only have to take the informed consent for LSCS, you have to take written informed consent for assisted delivery before proceeding for any surgical intervention, for blood transfusion, for any invasive procedure like epidural anesthesia. You have to inform her about the critical illnesses. You have to take written informed consent if for her baby requires admission to neonatal intensive care unit. and before inserting PP IUCD also. It should not be inserted without informed written consent. As far as the birth companion is concerned, yes, it is her right to decide who will accompany her. It can be her husband, it can be any relative. So you have to give an identification tag to that birth companion, and you have to gently remind him or her about the role as a birth companion. You have to tell them about the signs and symptoms that they need to observe and report immediately to the staff. Remember, birth companion is not there just to stand. They have an active role. You have to request the companion to offer emotional support to the woman during labor, help her to move around as she desires, talk to her, and provide comfort as required in the form of back massage, warm compresses, etc. As far as position is concerned, yes, again, it is the woman's right to decide which position she wants during delivery. Allow woman to move around and take any position she is comfortable. Walking, standing against a wall, sitting increases the dimension of the pelvic diameters and they help in the descent of head. So don't force her to lie down throughout her labor. Gravity does help in descent of the fetus and uterine contractions become stronger. Physical abuse, yes, it is still rampant. You should not pinch, slap, push, or hit the woman because she's screaming, she's demanding your attention, she's shouting. Do not tie the woman to the bed. Do not perform unnecessary episiotomies. You should be well versed with the recent guidelines that even primigravidas, they don't need routine episiotomies. Do not do postpartum suturing of episiotomy cuts without use of local anesthesia. Do not push the abdomen to force the baby out or use excessive physical force to pull the baby out. For privacy, you should not make the woman to labor and deliver in front of others without the screens or curtains. Do not forget to cover the woman with sheets during examination. She should not lie just naked and you are going and examining in front of others. Only those staff who are involved in the care of women, they should be allowed in the labor room, and do not share sensitive information such as her HIV status, age, marital status, medical history with those people who are not involved in her care. Dignity, yes, again, this is her right. You have to behave in a dignified and respectful manner with pregnant women and their relatives. Any yelling, scolding, shouting, blaming must be forbidden from your part. No abusing language should be used. Do not shame a woman for her reproductive choices and do not reprimand a woman if she calls for help. Do not discriminate on the basis of woman's religion, parity, caste, age, language, HIV status, traditional beliefs and preferences, her economic status, or educational level. Do not leave the woman to deliver by herself. Do not fail to monitor the woman in labor and to intervene in life-threatening situations. Do not ask the woman to clean the labor bed or floor after delivery. Do not ignore a woman's call for help and provide services according to the SOPs or guidelines. Do not demand money on the delivery of the child. Tell your staff also, they should not demand. Do not demand for the payment of those services which are promised to be free under the government schemes such as free blood, free delivery, free medicines, free food. Then you should not charge them and you should not demand money. So as far as Article 1 is concerned, every woman has the right to be free from harm and ill treatment. This I have already said. No one should physically abuse pregnant women. All physical contact with pregnant women should be as gentle, comforting, and reassuring as possible. Even though freedom from physical abuse is the right of each patient, many stories of physical abuse during childbirth have been reported. And these are the examples of physical abuse: pinching, slapping, tying her to the bed, doing unnecessary episiotomies, suturing episiotomies or tears without local anesthesia, and pushing the abdomen forcefully. Article 2, every woman has the right to information, informed consent and refusal and respect for her choices and preferences, including companionship during maternity care. So the examples of non-consented care are that you are not giving her information about the medical procedures, you are not asking for women's permission to conduct surgical procedures such as for induction of labor, augmentation of labor, for episiotomy also you have to inform her, cesarean section everyone is taking, sterilization you are taking, but for blood transfusion also you have to take written informed consent. Article 3, that is, she has the right to privacy and confidentiality. We have already discussed that no one should expose her personal information with those persons who are not directly involved with her care, because privacy and confidentiality again is her basic right. The examples are making her to deliver in front of others where there are no curtains between the two patients, and when healthcare providers are discussing her case very loosely with other fellow colleagues during duty. Every woman has the right for dignity and respect, so no one can humiliate or verbally abuse her. But yes, there are some examples where the healthcare providers are using harsh tone, harsh language, unkind expressions, dirty language, or abusive words because she is shouting in labor. So you are not allowed to scream or shout on the woman who is in labor. She has the right to freedom from discrimination and equal care. So even if you don't like, you have to give equal care to this woman. And examples of discrimination include discrimination based on race, ethnicity, age, language, HIV status, and traditional beliefs and preferences. She has the right to timely health care and to the highest attainable level of health. Remember, the examples of abandonment are that she is left alone during labor, she is not receiving any medical attention, women giving birth by themselves, where there are so many examples where they are delivering in the waiting area, they are delivering on their own, there is no staff to attend to them, there are other patients who are helping her to deliver, women are not allowed to bring a companion during delivery, and there are many cases where providers, they fail to monitor the woman in labor and provide interventions in life-threatening situations. Article 7, everybody should remember that she has the right to liberty, autonomy, self-determination, and freedom. No one can detain her or her baby without legal authority. Some health facilities have been known to detain women because they cannot pay their bills. You just can't detain them. I know this is usually for a day or two, but there are reports where these women have been detained for longer period of time. So when a woman experiences disrespect and abuse during facility-based care, remember her rights are violated. Often when this happens, more than one of her 7 rights are being violated at the same time. Around the world, in both wealthy and poor communities and countries, women have been and are experiencing disrespect and abuse. All women deserve respectful and dignified care during pregnancy and childbirth. It is understood that disrespect and abuse often fall into more than one category, so the categories are not intended to be mutually exclusive. They should be seen as overlapping along a continuum. And we all have a role in assuring that all women have respectful maternity care, because it is an opportunity to care for and care about our commitments, a challenge to meet and exceed client expectations, a chance for everyone to create the right impression for both clients and providers. So this is my last slide. Whatever I have talked, don't ignore it, because respectful maternity care is not an option. It is a right. This is a woman's basic right. So we all have to provide respectful maternity care. Thank you. Thank you so much for your patient hearing.
Hello. Am I audible?
Yes.
Yes, it's audible.
Can I invite Rashmi madam and Deepa
Yes,
madam?
yes. Thank you, Monica. Heartiest congratulations, respected Dr. Lakshmi Shikhanda madam, for your talk, par excellence as usual. Your talk clearly emphasized and focused that RMC is individual and human right, and also that respectful maternity care is not an option, but a right. So, as you said, madam, respectful maternity care should include autonomy, dignity, decision-making, and preferences of not only mother, but also her baby. Thank you very much, madam. Thank you so much for this lovely talk.
Thank you so much, Lakshmi madam. And we have all been seeing through years that we have all been involved into Lakshya program and Manyata program through FOGSI, and we have been trying hard to spread awareness about respectful maternity care, and it should be in the dignified manner. And today you have enhanced our knowledge regarding all the articles and all the rights that a pregnant female has, and she can ask for it. So I think majority of gynecologists at a junior level who are doing basic labor room duties, they are not that much aware about all these rights of a woman. So we all should work hard to spread more awareness regarding this, and you are an inspiration to all of us, and we all promise to work in this field more and more along with you. Thank you so much, ma'am.
Absolutely right, Deepa, because we all know about it, but our residents, we have to train them because they are really overworked, and if there are so many deliveries, so somewhere down the line, I mean, so it is our duty to tell them about the respectful maternity care. Yes.
Thank you so much, Lakshmi ma'am, for an elaborate talk, and thank you, Rashmi Pahar madam and Deepa ma'am for chairing this session. We now move forward with the next academic. Our speaker for today is Dr. Gaurav Desai. He is speaking on practical approach in challenging obstetric scenarios. Our chairpersons for today is Dr. Monica Gupta madam and Dr. Swati Bhargava ma'am. Dr. Monica Gupta madam is the West Zone Coordinator for the Public Awareness Committee. She is also the organizing president of Alwar Con. She is currently the HOD and senior consultant at Daksh Hospital, Alwar. We welcome you, ma'am. And our next chairperson for today is Dr. Swati Bhargava madam from Indore. She has an active participant in the advancement of field of OBGYN with multiple chapters and articles in various books and international journals. She is an ex-associate professor in the Department of OBGYN at MGM College, Indore. We welcome you, ma'am. I request you to please introduce our speaker for today, Dr. Gaurav Desai.
Good evening, and I thank the organizers, Dr. Monica Madam, and the Public Awareness Committee to have given me this opportunity to chair such a prestigious session by the versatile speaker, Dr. Gaurav Desai, sir. He is an gynec and pelvic endoscopist from PD Hinduja and KEM Hospital, Mumbai. He is a managing council member at MOGS and assistant secretary, FOGSI Journal. He's speaker for many FOGSI programs and AICOGs. He has been awarded FOGSI Seuli Rudra Sinha Award and CS Dawn Yuva FOGSI Award. I welcome you, sir, for the talk.
Okay, thank you so much, madam. At the offset, I'd like to thank Priyankur and the Public Awareness Committee, as well as all the respected seniors and dignitaries who are here. I think Priyankur and I have had so many of these webinars and sessions, especially during COVID, that I've lost count on how many programs we've had. So when he called regarding this obstetric webinar, I thought, I mean, of course, I do a lot of endoscopy, but I also run a high-risk obstetrics unit where we have various challenging cases, and these are all real-life scenarios which are happening day in, day out, all across India. Now, as Madam was talking about respectful maternity care, a lot more. We've actually come a long way from what we were maybe about 5 or 10 years ago, but there's still a lot of work still to be done. And, a lot of these challenging cases come up. A lot of them are surprise cases. People don't really know how to manage them. But, as experience and as you become more and more senior, these come about quite naturally to you. So we first start with the first case, which is a lower uterine segment tear and colporexis. So here we have basically, this was a case of a 29-year-old woman with a previous LSCS who underwent an emergency LSCS due to fetal distress in the second stage of labor. And she, of course, had second stage arrest. And of course, the operator who was there was a fairly junior resident who, after the delivery, gave me a call and said, please, can you come down and help us out? When I came there, this was the image that was presented to me. Of course, on inquiring, the inexperienced operator did not really, lift or push the head up and flex the head correctly before removing it out. And on examining this, this was, before, after the bladder was pushed down. But, the picture after the bladder was pushed down was something like this. It's fairly intimidating for quite a few junior doctors and junior gynecologists. But in, of course, our unit, we handle quite a few cases like this. And this can actually have quite significant morbidity post-op if this is not managed correctly. So the first thing is, of course, try to clear the field of vision. This is actually quite a clear vision. Initially, there was bleeding because, the placenta is just separated. There's a lot of blood bleeding at this stage, which can cloud the whole operative field. The next thing is to actually find the lower edge of how far, how extensive is the rent, or is the the defect. So you have to have very good pushing down of the bladder. Make sure that the lower part of this tear is actually seen. Of course, here in this case, it went right from the lower uterine segment in through the cervix and into the vagina. So we have actually pushed the bladder way down. That is the first thing that you need to do. Secondly, once you have that lower edge, you're fairly confident that you can now close it. Remember, you have to actually identify the cervix, the vagina, and the lower uterine segment. So this is extremely important. So risk factors for this include, of course, previous uterine surgery, like either a hysterectomy and LSCS, a fairly large baby, which can sort of cause problems of, it's difficult to push that baby up or flex the head. Maybe there is a baby with a large hydrocephalus, which can cause some problem. Any malpresentations, malpositions, compound presentation, any breech presentation. So that these things can sort of cause this. As I said, inexperience of the doctor can also, lead to this second stage arrested obstructed labors. They frequently, once you put your hand in and you remove, you find a fairly large tear. Sometimes it extends laterally to involve the vessels, and sometimes even quite caudally, like in this case. So precipitate labor, these are some of the risk factors for this. So as I said, these were the main steps that we conducted. And, how do you manage it? Well, first of all, one can use Ellis forceps, any such instrument, and I prefer at least to suture it in 2 layers. Take an inner layer and, of course, reinforce that layer, the second layer, to include the slightly superficial tissues. So I usually use number 1 or 10 Vicryl. And like how we suture episiotomies or any rectus sheath, make sure you take the angles and the apex, which is included. And of course, this must be documented because, now today, in today's day and age, women are actually moving from one place to the other. There's a lot of migration from outside Mumbai city into Mumbai and from Mumbai outside. So you don't know who the next gynecologist will be and where she will be having the next conception. So if she does have the next conception, the next person has to be aware that this has occurred, and it should ideally be a cesarean section at the next delivery. Next, we come to an entity called unscarred uterine rupture. Now, frequently, we are, of course, we have a lot of referrals in our unit. So we encounter such cases where in the periphery, they actually start the process of labor and the induction, and midway through it, or if there's some problem, they shift it to our unit. So here, this is an example of a referral patient, a primary gravida who was actually low risk, had absolutely no comorbidities, no diabetes, no hypertension. She was conceived for the first time naturally, who basically had undergone an induction of labor at term. So it was quite expected management. And then she basically was referred to us because of failure of induction, and they thought the heartbeat, there was something amiss about the heartbeat. So once we received her and all, and she underwent an emergency C-section for that. Now on the cesarean section, once we did posteriorly, this is the posterior image. So this is the back of the uterus, and it basically shows this rent or this rupture, which is on an unscarred uterus. So it was actually quite significant. The baby was, of course, had a fairly low Apgar, was intubated, and we were presented with this. So that, the dilemma is what should be done about this. Is there more damage than what is actually seen on the surface? It was actually quite surprising, because the resident who noticed it usually noticed it once they exteriorized the uterus. And this is the picture that was seen. So one of the main risk factors are, for example, of unscarred uterine rupture in literature is grand multiparas, when there is instrumentation which is involved, any malpresentations, induction of labor. But usually these posterolateral ones, at least in my experience, have been because of some excessive forces of to push, excessive uterotonics which are used. Sometimes, especially in these which are referral patients, we are always suspecting that there is something amiss. There is, you don't know what has been done. I mean, there is no documentation. Sometimes the misoprostol and prostaglandin gels are mixed, and that sometimes causes this type of picture. So, as we say, don't mix drinks. You also don't mix uterotonics. Again, like before, first thing is to just clear the field of vision. This is actually the picture after the, all the, usually C-sections, I mean, any rupture is quite a bloody picture. So that is one thing. And the second thing is just make sure certain vital structures are fine. Like, for example, uterine vessels, make sure the ureter is okay. Once this is done, check the urine bag. These are just basic things which can be done during this uterine rupture. Again, suture with number 1 in 2 layers. You can use 1-0 Vicryl, or I prefer number 1 Vicryl. This has to be, documented again. Again, we advise not to have a very short interconceptional period. Use an interval contraceptive, and the delivery, if at all, the next one should be an elective cesarean section. So, 2 fairly unique, but nonetheless things that actually happen in a day-to-day life of a gynec surgeon. Next, we come to something that has, of course, been discussed before in many webinars, a low uterine segment fibroid during a cesarean section. So just a typical picture. Of course, usually sometimes it's a fairly small one at an angle or just at one corner of the edge of the uterine incision. But here was a patient who delivered with a planned cesarean section, and this suddenly pops out. It's actually not so apparent, the baby comes out, the placenta comes out, and then once the placenta is removed, this thing is absolutely powdered. You can't even see the lower edge. So it's difficult to close the incision. People might say cesarean myomectomy or not. Well, I mean, that depends really on operator experience. There are some operators who say, yes, we should remove. Some who do not say, it's a little scary, intimidating. There might be blood loss. So one depends on operator experience. Secondly, it depends on where you are also. I mean, I've operated in fairly in setups where there wasn't a blood bank available. There are various challenges even in some of the metropolitan cities. And of course, others where you have a lot of help at hand. You have seniors, you have people who can help with getting blood products. So, it really depends where you are also. One thing is, of course, I always, if I'm with a scenario like this, I would check the posterior wall. You look how it is, how relaxed the uterus is, or how contracted the uterus is. In such cases, I would first try to reposit that fibroid. Just take a fist and try to push it inside. And sometimes that does at least show you that lower edge. Once you see that lower edge, just apply a few Ellis clamps. Try to get around that fibroid and try to find that angle on each side. It's easier said than done in these situations. And sometimes the uterus violently contracts and you're kind of helpless. But this will sort of help you, like in this case, where this intimidating fibroid was actually closed. I mean, it's a little difficult because, see, sometimes what happens is that apart from operator inexperience, it's difficult to access, internal iliac, the vasculature to ligate, things like that, in the cesarean section. So sometimes it's good to close, monitor the fibroid post-operatively. You can always operate on this later. I mean, do a lap myomectomy or whatever one is comfortable with. Okay. Now, the other sort of scenario we have is talking about tumors in pregnant women. We get quite a few cases. I mean, the referrals from gastroenterology, referrals from oncology. We have Tata Memorial, which is just opposite to us. So we get a lot of pregnant women who have some sort of tumor in the body. This is fairly challenging depending on tumors. I mean, for instance, if there is a rectal CA, then I mean, we've seen rectal CA in 29, 30-year-olds. We've seen, cases of thoracic tumors. So we get all this. Of course, I have oncology background. So they, of course, send quite a few. One of the challenges is, of course, how do you manage, how do you counsel these patients? It is quite a difficult scenario because some of them do want the child to at least survive because the mothers have a poor prognosis. And then, of course, is the dilemma of how do you time the delivery, because here we also want fetal maturity. On one hand, we want the mother to be, fit enough to undergo labor. And of course, it should not interfere with adjuvant because you don't want, a lot of chemo or radiation therapy to interfere with the pregnant woman's life. So it is a challenging situation. I mean, this is just one example of the cases some of the cases we get. So you have certain, this is a 27-year-old Priney gravida. She was came on about 28 or so weeks, have been in the in the late second trimester. Large thoracic tumor, which was there. The family was explained, of course, the prognosis from our colleagues in TMH. And the parents were still keen on having that child, even though it would have been preterm. So, you can see this radiograph, which shows that entire neuroectodermal tumors involving most of the thoracic cavity. So it's fairly large. And in this situation, we were given a very small window to try and deliver. Of course, undergoing a cesarean section itself is quite stressful for a woman like this. We had fitness issues. Anesthetists were not very keen on doing operative intervention. in such a case. So it was very important that we induce her properly. So I myself induced this patient, and she delivered fairly quickly. It was a stressful thing for her, but the baby did come out. It was preterm. It was shifted to the neonatal care unit, and eventually, fortunately, did survive. So that was a good point. Of course, she unfortunately had to go back for adjuvant therapy, and of course, a few cycles after that succumbed. But that's the reality of life, and we did what we could. The next scenario is something that actually, it hasn't happened for many years, but eventually I was sort of presented with this scenario where a 32-year-old woman, actually, she had undergone a vaginal delivery, no instrumental intervention, but she had an episiotomy. The episiotomy, as usual, was sutured with number 1 Vicryl, but she came back 1 week after that with an episiotomy which wasn't healing and with fecal discharge. So, of course, we knew there was a connection between the fecal passage as well as this episiotomy. So, important in these cases, these are, of course, known as buttonhole tears. Do a good per-rectal examination. Risk factors for these are things like precipitate labor, use of instrumentation, a very large baby. Sometimes what happens is there is a lot of pressure during delivery as well as the rectum. And if that ischemia is caused in that area sort of falls off and forms a connection between the two. So, principles of management of this are just clean or freshen the edges. And one has to have a good plane between the rectum and the vagina. So, to sort of suture it in 2 different this case was successfully managed. There was no need of a colostomy or any such thing. The patient is absolutely fine now. But it's important to have 2 separate, layers and suture it correctly. Now, obstetric hysterectomy, really, there's nothing much to say. All I have, the recent advances I wanted to just highlight. If one is operating in any setup, it's important to push the bladder down as much as possible. There are, of course, now alternatives. I remember speaking to Dr. Arul Kumaran about what is done now. And of course, if there is adherent placenta, instead of going for a straight obstetric hysterectomy, they actually excise that uterine tissue around that adherent placenta and suture the uterus. The uterus remodels itself. That's about it. This make sure bladder is pushed down, check the ureters after you do this, just basic steps. And finally, I come to one of my passions of endoscopy, and on doing a webinar like this where you're dealing with safe pregnancy and safe motherhood, I thought, why not talk about laparoscopy in pregnancy? So the recent case where you had large ovarian cyst which had undergone torsion. Patient came with pain. She was a case of previous LSCS, about a 30-year-old patient. She had previous LSCS about 13 12, 13 weeks. And she came with this USG which showed dermoid, which had slightly twisted. So important to know that, in such situations, of course, vaginal manipulation is an absolute no-no. But apart from that, you can put a Susten pessary. You can, we usually try to put a Duodelant drip, not that it is compulsory. And apart from that, insufflation is absolutely fine in such situations. There used to be a concern by anesthetists and by gynecologists about using certain anesthetic gases, but now the anesthetists are fairly confident that there is no teratogenicity. Once we went in, we looked, since she was a previous section, there were some adhesions. There was also a ventrofixed uterus, so we removed that with bipolar energy and scissors, and everything was done with just basic bipolar and scissors. So here you can see a cyst, which is there, fairly large dermoid. These have a propensity to sort of twist around. because of their contents. We place an endo bag, open the cyst, we try to suck out as much as liquid material as possible. Then we sort of dissected out that material within the endo bag, and then pulled out that endo bag through one of the side ports. Fairly well done. There was no spillage, and the patient has now been discharged. So, these are the few of the scenarios that we encounter, and it's important to sort of emphasize that even though they're challenging, one has to follow certain protocols, one has to make it safe, however grave the situation. So thank you so much, and I'll be happy to answer any questions.
Monica, ma'am.
Thank you, sir. Dr. Gaurav, it was an excellent case presentation, so many cases. And as we know, obstetric is a branch of uncertainty. Emergency or complication can occur at any time. Whenever we are having a risk factor before, it is easier to explain to the patient. Patient is having a fibroid, patient is having CA cervix or whatever the things. But many times what happens, it is an absolute normal case and you land up in a problem. So it is my suggestions to the younger generation ki you should have confidence. First, you have to confidence. You have to keep yourself cool. And secondly, don't hesitate to call to the senior for the help. If you are confident enough, you manage it. If not, better to take a help because every life is important. And if something is going to wrong, you are going to land up in a mess. So thank you very much. It was an excellent talk. So such a nice cases, and you can go on talking on this topic because in obstetrics, everybody is having a lot of experience and lot of complications are there, which one has faced. Thank you very much.
Thank you, madam.
Swati, ma'am, you there?
Yes. Thank you so much, sir, for such an insightful and amazing talk and with full of cases. And actually, the solutions to it were also very approachable. As it is said that every challenge needs a mindset to overcome it. Thank you for providing that to all of us. Thanks a lot for the talk.
Yeah, most welcome. Thank you all for inviting me. And of course, it's always good to share knowledge with Foxy family. So thank you so much.
Thank you, Swati ma'am. Thank you, Monica ma'am, for chairing the session. And thank you, Dr. Gaurav, for an insightful talk. We now move forward to our next academic session, that is the panel discussion on near-miss cases. Can I invite Dr. Shatabdi to please coordinate the panel discussion?
Thank you, Monica. Those were indeed two very wonderful talks by Dr. Gaurav and by the ever-dynamic Dr. Lakshmi ma'am. Now we'll move on to a very, very interesting panel discussion coming up. Today's panel discussion is on near-missed cases, which is a very, very important topic and very, very important thing that we deal with in our day-to-day obstetrics practice. We have two very dynamic moderators with us, Dr. Sneha Bhuyar ma'am and Dr. Dolly Mehra ma'am. It's my honor to introduce Dr. Sneha ma'am. Dr. Sneha ma'am is, of course, a senior consultant in obstetrics and gynecology. She is the international MS signature. She's had many awards to her credit, more than 30 plus chapters and articles in various national publications. She has been the Foxy Breast Committee chairperson, the GCM ICOG chair, the National Adolescent Trainer, and various other designations to her credit. Welcome, Sneha ma'am. Our next moderator is Dr. Dolly Mehra ma'am. Can I have the slide, please? Yeah. Dr. Dolly Mehra ma'am is a consultant at Mehra Nursing Home at Ratlam, MP. She has been the president of the Ratlam OBGY Society. She has been the organizing chairperson of the MP State Conference of AMPOGS, zonal coordinator of Foxy, as well as the joint secretary of the AMPOGS. Till present, she has been the faculty at various national and state conferences. Welcome, ma'am. Our expert for the panel discussion is Dr. Archana Dwivedi, ma'am. Can I have the slide, please? Yes, Dr. Archana Dwivedi, ma'am, is the national chairperson of the IMS website committee up till 2025. She has been the president of BOGS, president founder of MSV, as well as the secretary of the women's wing of the IMA. And she has been practicing in Vadodara since the past 20 years. Welcome, Archana ma'am. We have a very interesting group of panelists today. Can I have the slides, please, Ruchi? Hello?
The next slide, please. We have to introduce the
Ruchi?
panelists.
Yes, move on to the next slide, Ruchi. Yes, next slide, please. Our first panelist is the very dynamic Dr. Monica Singh, ma'am. Ma'am is a consultant of reproductive medicine at the Bhopal Fertility and Endoscopy Center, as well as a professor in IN Medical College, Bhopal. She is the managing committee member of ISAR, vice president of BOGS, as well as the vice president of Bhopal Menopause Society. Welcome, Monica, ma'am. Our next panelist is...
Hello.
Our next panelist is Dr. Pratibha Chavan, ma'am. Ma'am is a consultant obstetrics and gynecologist, as well as the president of the Gadinglaj Obstetrics and Gynecological Society. She practices at the Sant Gajanan Maharaj Rural Multi-Speciality Hospital at Madgaon. She is also the director of the Sant Gajanan Maharaj Education Group. Welcome, Pratibha, ma'am. Our next panelist is Dr. Jigyasa Dhingra, ma'am. She is a director and consultant at Mahi IVF and Women Health Center at Jabalpur. She is the secretary of the JOGS. She is also the editor of the JOGS as well as the joint secretary of JOGS. Welcome, Jigyasa, ma'am. Our next panelist is, next slide, yeah, Dr. Sapna Kaswan, ma'am. Ma'am is a practicing gynecologist at Noble Care Hospital, Shikar. She has a fellowship in reproductive medicine. She is presently practicing as an IVF specialist at Noble Care Hospital, Sikar. Welcome, Sapna, ma'am. Our next panelist is Dr. Amruta Kumthekar, ma'am. Ma'am practices as a consultant obstetrics and gynecologist at Kumthekar Multispeciality Hospital at Solapur. She has been practicing since the past 15 years. She has co-authored various articles in various national journals. Also worked as a clinical secretary of Solapur Obs-Gynae Society in the year 2021. Next slide, please. Our next panelist is Dr. Ritika Gupta. Dr. Ritika Gupta is an IVF consultant at Kamala IVF at Alwar. She has done a fellowship in minimal access surgery. She has won the best paper award at Alwarkon, Rajasthan, as well as is a social worker for the Arman Foundation. Welcome, Ritika, ma'am. Our next panelist is Dr. Vaibhav Nadkarni. He is a director and consultant of Obs-Gynae and Infertility Specialist at 21st Century Hospitals at Vapi, Valsad, and the Nadkarni Hospital and Test Tube Baby Center at Killapadi. He is involved in training OBGYNs at the Nadkarni's Academy at Killapadi in infertility for various years. Next slide, please. Our next panelist is Dr. Ashwin Vachani, sir. Sir practices at MP Shah Medical College, Jamnagar. He is also the member of the National Academy of Medical Sciences, New Delhi, and the professor and head in the Department of Obs-Gynae at Swimmer, Surat, and has been the president of the Surat Obs-Gynae Society. Welcome, sir. Next slide, please. Yes, now I hand over the, yes, next slide, Ruchi. Yes. So now I hand over the stage to Dr. Sneha Buyar, ma'am, and Dr. Dolly Mehra, ma'am, to carry on the panel discussion. Looking forward to an excellent session.
Hello.
Sneha ma'am,
Yes.
Dolly madam has an emergency PPH, so she will join in a few minutes.
Yes,
And
yes.
Amruta is in a cesarean section. She will also join, ma'am. Rest everybody is there.
Yes, yes, yes. So thankful to God, I also landed up into emergency with the, ferric carboxymaltose injection, severe reaction. I, in fact, never faced thousands now given till now, but I just could manage to, manage it. So I am sorry for the delay, and I welcome all my panelists who have been already introduced. So I think, can I share my screen? Yeah. So I hope my screen is visible. I'm trying to make it full screen.
It is visible. You need to make it full screen.
Yeah. I'm sure you can see it now full screen. Okay. So friends, welcome.
Please unmute yourself.
Is it? Okay. I'm here. Oh, I actually, let me actually.
You are audible, madam.
Yes, that's what I'm saying.
You are audible.
Now I can hear you, ma'am.
You are audible.
Okay. So a very good afternoon to all of you. Look at this picture, the simple normal vaginal delivery on, you are just starting with, and you are expecting everything good, a healthy baby from a healthy mother. You don't know at what point of time your patient, can land up into, and she may be shifted to either obstetric SDU or ICU. So obstetric is bloody filled, very, very unpredictable. And if she is lucky enough, you can save her, and that is how we label it as near miss. So friends, this terminology we have borrowed from the airline industry. Look at this, what is happening here. It is just a near miss. So it tells you the gravity of the situation and the urgency, it demands. So how fast, how quickly, how effectively you should act, that is what, the message here is. So every case, I'm sure all of you are managing cases, but every case is a different experience and it teaches you something different. So friends, don't stop learning because life never stops you teaching. So near miss, I'm sure all of you are aware by now. It's the pregnant woman who have almost died but survived the complication of pregnancy, childbirth within 42 days of termination of pregnancy. And had it not been the luck or the good care from her side. So that is how it is defined. It is also termed as severe acute maternal morbidity by WHO. And the survey is very, very important. Analysis and discussing these cases is very important because that will give you an insight how you have managed. It will help others also, and how to improve yourself. That will also be, it will be a benefit for you. And that is why for every case, we're going to introspect at the end of the discussion. And we are going to say that, how we should have managed, or how we could have prevented. So I'm not going to go into the details of all this theoretical aspect. I will start straightway with Dr. Mona Shroff. Do we have Dr. Mona here? I'm sure all the panelists are here.
I am Dr. Ashwin Vachani in place of Dr. Mona Shroff.
Okay. So Dr. Ashwin, what do you think is the problem rising, or, hello?
Yes, madam.
What do you think that is the problem rising nowadays, or it is just the same, only we are detecting it much more frequently? What do you feel?
Yes, madam, problem is already there, but now we are recognizing it because we are given the more importance to the maternal death. And not only this, one maternal death, there are severe maternal morbidity in almost around 20 another. So it is multiplied
I would ask
by 20.
the other panelists also, do you agree that it is just the same as previously, or it is increasing? Do you find
some problems are, should I, ma'am?
Yes, please.
Some problems are rising, just like because obesity is increasing, GDM is increasing, cesarean section incidence is also increasing.
Perfect.
That's why,
Anybody else wants to add anything? Why these problems are rising? Why these problems are rising? Yes.
Diagnosing more frequently, more easily we are diagnosing.
Yeah, anybody else? Ritika, Ritika, can you talk about this? Why the problems are increasing? We are sure that it is increasing. Okay, Monica.
Yes, ma'am. May I
demography.
Previous cesarean section.
Yes, ma'am. May I?
Yes, please.
This problem is increasing because of most of the cases we are getting the high risk pregnancy. We are getting a pregnancy in advanced ages. We are getting a pregnancy with obesity, IVF pregnancies. They are already high risk pregnancies. So that's why the incidence is also increasing.
And also the associated, multifetal pregnancies, and then the precious pregnancy, and then comes the cesarean section and associated complications. Okay, so that is why these problems are definitely on a rise, and the reasons being varied, but definitely the demographic of the obstetric population is changing. So we come to you, Dr. Monica Singh. We have this second gravida, previous cesarean section, only 1 year old child, she comes to you with 7 days overdue, and she doesn't want to continue the pregnancy. She does her UPT, it is positive. Okay, so she wants to go for medical abortion. The doctor prescribes MTP kit and asks her to come for follow-up 7 days later. So, suddenly on almost on 6th day, she is brought to your hospital by the relatives in a collapse condition. The pulse rate is 132, BP is 70, valor is plus. What is your differential diagnosis, Monica?
So the MTP kit was prescribed without diagnosing.
What is your differential diagnosis? We are discussing only the management at present.
I will first of all think ectopic.
Yes.
That is the first thing which will come to my mind. And
ectopic only.
Yeah.
But then what kind of ectopic you are expecting here?
I'm expecting the most common is tubal ectopic. It could be a tubal abortion. It is less likely to be a rupture at this stage. It is more likely to be a tubal abortion. And
her pulse rate is 132. Her pulse rate is 132. Her blood pressure is 70. Okay.
So there's
She's in
hemorrhage.
shock.
There is intraperitoneal. There is intraperitoneal hemorrhage.
So
She
rupture
either had a
ectopic
tubal
pregnancy or
abortion
scar
or
ectopic even.
ruptured ectopic.
Yeah. So you have to keep a differential
So
diagnosis
there
here
could be
because
a
it's
scar ectopic. Yeah.
yeah. Okay. So your
It could be a
diagnosis
scar
is
ectopic also.
Yes. Monica, yes, please go ahead.
So the
Hello?
ectopic could be anywhere. Since she's a previous section, we would also think in terms of scar ectopic. We would think in
Yes,
terms
that
of,
is what.
tubal. Yes.
Okay, so your diagnosis is ruptured ectopic pregnancy. Okay, now, so when you bring this, this patient is brought to your hospital, you find that she's in shock. How would you manage this patient?
Urgent management of shock condition, madam. Start an IV line, do bedside CBC. Here we find the hemoglobin is 7 gram%. And
Yes.
now the, ultrasound availability in midnight is very much possible in most of the obstetric units nowadays. They are having ultrasound. So at least you should be able to put a, transabdominal or a TV probe and see the
Okay.
collection in the POD.
Okay,
Should be
so
able
it shows
to
at nasal
differentiate.
mass,
There is
lots of
no
pre-fluid.
sap inside.
Yeah.
Yes,
So,
yes.
so how will you manage now? Going ahead.
Now it depends again on the expertise. I would still like if I can find a mass there, and if I find not too much of intraperitoneal collection, I would still like to do a laparoscopic procedure. But
Dr. Monica, she's already in shock. There has to be lots of collection in the peritoneum. There is a massive hemoperitoneum. Okay, the blood pressure is 70. So you're right that her diagnosis is ruptured ectopic pregnancy, most probably a tubal rupture ectopic pregnancy. Now the question is whether you would like to go for laparotomy or laparoscopy.
Madam, here the laparotomy would be more advisable because you can do it more rapidly. You will be able to, resuscitate her faster. There is at the same time a informed consent for aggressive, the blood transfusion and fluid management. You have given a sort of, all the consent to the relatives. You've taken consent. With laparotomy, you'll be able to catch the bleeder faster and curtail the hemorrhage. Maybe the laparoscopy will take more time. And definitely conservative surgery is not indicated here. You might have to go for a
Because it's a
salpingectomy.
ruptured tube, it's a damaged tube, right? Okay,
Yeah.
so you don't want her to have again a second recurrent ectopic pregnancy. So naturally, it's a salpingectomy. There is a consensus. But laparotomy, laparoscopy, there may be differences of opinion because if you have the expert gynae endoscopic surgeons, the laparoscopic surgeons, they would still say that, even the whole peritoneum is full of blood, they can suck it out and catch hold of the exact point. That is what people are claiming. And when you have the expert laparoscopic surgeon, you can do this even equally effectively by laparoscopically. Okay, so that is what is the management of this patient. What is the learning lesson? What message you want to give, Monica? What has gone wrong and where? How do you want to correct it?
Medical abortion pills are available over the counter in our country. So though it has given a lot of freedom of choice of medical abortion to the women,
Yeah, but this is
pregnant. But
not
ma'am, the problem is,
patient. This is
ma'am,
the doctor has given it. What do
yes, the
message you
doctor
want to
has
give
given
to
it.
the
So,
doctor?
ma'am, actually, if the doctor has given it, especially if a gynec has given it, he or she should make sure that the pregnancy is intrauterine before giving it.
Correct.
It is very much possible to see a sac of even 4.5, 5 weeks, you can make out a sac.
Yes.
So you can make out a sac and then confirm that it's an uterine pregnancy. And in the previous section, it is not at the region of the scar. And once you confirm it, and it should be less than 7 to 7.5 weeks. Nowadays, more than 50% of the patients are taking these MTP kits when they are over 7 weeks of gestation. So
Yeah.
that is why it leads to a lot of complications.
Okay, so immediately my next question to you is that whether it is a mandatory to go for ultrasonography by law.
Ma'am, by law, it is not mandatory. It is good practice point. It is a good practice point to do ultrasound, but definitely you cannot withhold MTP kit saying that ultrasound is not done. I will not give you the kit.
Yeah.
You have to give, but at the same time, you have to take it with a pinch of salt. The pregnancy might be anywhere.
In fact, I would say the
so
other way
ectopic
around,
preg-
Monica, that it is, though it is not mandatory by law, it is for the safety of the patient and safety of the doctor, it is recommended that we go for ultrasonography, confirm that the pregnancy is intrauterine, then only you should give the MTP pills. That is
Madam,
what should
madam,
be
if the
the
gynecologist has given the pill and by chance she loses the patient or he loses the patient, ruptures the ectopic, collapses in some peripheral hospital. So won't that be a legal binding on the doctor who gave MTP kit without doing ultrasound?
That is what I'm saying, that in fact you make sure it is recommended that for the safety of the patient and safety of the doctor, she should go for ultrasonography. So the very simple statement is, it is not mandatory by law, but it is recommended. It is a good practice recommendation. Okay. So you have discussed the case very well. And this message is very, very simple and loud that yes, you must do the ultrasonography. You have to confirm that the pregnancy is intrauterine, even though law doesn't force you to do the ultrasonography. Okay. And
can I make a point, ma'am?
Yes,
yes. Can I make a point?
Yes,
ma'am,
please.
I advocate that what you're saying, ultrasound is mandatory because sometimes patient may be having a cyclical bleeding. Forget about ectopic. There can be a pregnancy in situ.
Yeah.
So I think whether law recommends or not, sonography should be done because exact gestational sac age is also very much required.
You have to, yes, you're right. So our message remains the same, that ultrasonography, though not mandatory by law, it is recommended for the safety of the patient and the doctor. Okay. So all of you make a point of this. Thank you so much, Dr. Monica Singh, for that wonderful discussion. And now we go to the second case. Here we have, this 36-year-old woman who conceived after IUI. Her husband stays in Dubai and she stays in a village. But because this is a precious pregnancy, she came to you for regular antenatal checkup. At around 24 weeks, you tell her that everything is normal and she's happy. She went to the village and, at 34 weeks, she reports to the primary health center saying that there's a pain in upper abdomen, there's pedal edema also. When the doctor at PHC takes up BP, it is 176 by 116. There is mild fetal growth restriction. The size is less. There is proteinuria. And the BP was high, so the tablet nifedipine retard was started. Okay. Now this patient was advised admission. She was counseled for the possibility of early intervention and referred to higher centers. So she did not get admitted, Dr. Pratibha. This is a question for you. So she did not get admitted to the primary health center. After 2 days, she got admitted to the higher center, that is the sub-district hospital, where they have, the anesthetist and all the facilities for cesarean section. So they do her cesarean section, but before that, they find that the blood pressure is still 168 by 110. So they added tablet labetalol to this, okay, and just started magnesium sulfate. Now, after the cesarean section, in spite of tablet labetalol and nifedipine retard, her blood pressure always remained high. That is 140 to 180 systolic and 100 to 110 diastolic. So now this patient, after almost 24 hours of cesarean section, she suddenly developed severe cough, breathlessness, restlessness, and her oxygen saturation started falling to 70. Her blood pressure was 220 by 118, and chest was full of wheeze and there are no clear breath sounds. What is your differential diagnosis, Dr. Pratibha, and how would you like to manage?
My first diagnosis is more towards the pulmonary edema, and pleural effusion may be there secondary to such a high BP. And pulmonary edema is there, that's why, and her saturation is 70%. So immediate call for the help, as well as need for the oxygen, high flow oxygen, around 8 to 10 liter per minute. Along with that,
What is that? 8 to 10 liter per minute. What is that?
Oxygen.
Okay.
High flow oxygen.
High flow oxygen.
High
Correct.
flow oxygen.
Okay. So first
along
thing,
with
what
that,
can you do? Your diagnosis is pulmonary
more towards the pulmonary edema
or embolism, but
embolism, or it could be pleural effusion also.
No, pleural effusion doesn't manifest such drastically. Pulmonary edema and pulmonary
embolism is more.
Okay, these are two acceptable diagnoses. But how will you manage this patient now?
By giving proper position, and by mask oxygen, high flow oxygen.
Correct.
Lasix immediately, around 40 to 80 milligram Lasix.
Perfect.
Then we have to manage her 220 by 118 BP. We have to start the labetalol injection, like 20 milligram.
So now I would ask Dr. Jigyasa. Pratibha, you have discussed the initial management very well. I would ask Dr. Jigyasa, how do you give the labetalol? How much? And how much time do you wait for that? Do we have Dr. Jigyasa here? Or you can continue, Dr. Pratibha.
Can I add?
Labetalol injection.
Yes, you can continue, Dr. Pratibha. You can continue.
In my setup, we are giving by syringe pump. Usually, this initial bolus dose of 4 ml means 20 milligram by IV push, and then after that, like that 20, 40, 80, like that. But in my setup, we are always shifting such type of patient in ICU, and that's why we are giving by syringe pump.
Yes. So, Dr. Ashwin, we would like to know from you, how are you giving injectable labetalol? Dr. Ashwin?
Yes, madam.
Yes.
We can give the injectable in stepping dose. We have to wait for 10 minutes whether it is effective or not. For example, first injection 20 milligram, we have given slowly IV bolus. We have to wait for peak effect up to 10 minutes. If still not controlled, then we can step up by 40.
Correct.
And if some government institute where injectable and the syringe pumps are not available, for example, some PHC, then we can use simple nifedipine also in step-up dose.
Yes. So
best one is the injectable labetalol.
Okay, what is the maximum dose for labetalol IV?
20, 40, and 80. That is, we can
So
go
220 milligram.
Yes, maximum 220.
220 milligram maximum. Okay. So what is the second dose here? What is the second drug for
nifedipine is the second drug. Capsule nifedipine, madam. Capsule nifedipine.
Perfect. That is what the answer is expected. Capsule nifedipine, the orange color capsule, 10 milligram that you have to give stat. And because it is quite effective to act urgently. So action comes within how much time? But is this the time to give oral? Because the patient 220 by 118. So here we don't have this option. Okay, we have better that we go for IV labetalol, and then of course for such a serious patient you have to shout for help, not only call for help but shout for help. So in addition to the drugs Lasix and the IV labetalol, what else you want to give?
One more thing, madam. Sublingual. Any comment on sublingual nifedipine which is used in the past, now not used?
No. Yeah. Absolutely no to
no. Yes, madam. Yes, that I want to convey.
Okay, so she was given Proctor position, oxygen, high flow oxygen was started. She was given labetalol injectable, as you have all have described very nicely, 20, 40, 80, and repeat 80 maximum. You can give up to 220. Lasix 40 milligram IV bolus is given, and then of course. In addition, when she has got, wheeze all over, you may nebulize the patient, okay? Unless you open up the bronchioles, the oxygen also will not reach. So that is how, you have to, so this patient was being, managed effectively, as all of you have said, but it was so catastrophic that when these things were being done and she was shifted to ICU, she went into cardiac arrest. Now what to do? What to do ahead? Who will take up this question? I'm sorry, I think I'm not able to see all the panelists. So can anybody volunteer, please?
Yeah, cardiopulmonary resuscitation.
Resuscitation.
Yes. What else? But how do you do that? It's a very important question.
30 pushes and just below the sternum, we have to give the cardiopulmonary resuscitation. And 5 centimeter deepening of the chest wall. 30 compressions and 5 centimeter deep.
Yes.
Chest
Very
should be.
good. Very good, Pratibha. You have to give 30 compresses. Chest
And there should be some release
lower
in
end of
between.
the sternum. And you have to give it, quite with
times.
force, that, there is a depression of the chest wall by 5 centimeter. And then it should rebound. Okay. And for every 30 compresses, you give 2 breaths. Okay. Okay, so that is how it is, then of course, what are the drugs? If at all it doesn't respond to it, continuously you give dopamine, dovitamin, maybe even sometimes you may even need the adrenaline, but for that you have to have your intensivist with you. Okay, so fortunately, the intensivist was there because the patient was being shifted to ICU. So after 1 hour of all this management, the patient came on spontaneous respiration. BP was 100/64. Yet the confusion prevailed. So we have, taken the patient to such a moribund condition. So I would like to ask all of you that what went wrong for this patient right from the beginning, and where, at what stage, what's this really preventable? Yes, start from first panelist, Monica. What went wrong? As a IVF specialist and imaging expert, I would ask you, right from early pregnancy, do you feel that you could have detected this patient? You could have predicted that she's going to land up into some complication of hypertensive disorders of pregnancy on ultrasound? You could have something.
Ma'am,
Yes.
nowadays the detection of hypertensive disorders of pregnancy need not be delayed. Right at the time of, apart from the history and the condition of the patient, whether she's obese, whether she's a family history, whether she's a past pregnancy with HDP, right from first trimester, we have got a scan called NT-NB scan. At the time of NT-NB scan, we did do the mean uterine artery PI. With the mean uterine artery PI at the time of NT-NB scan should be less than 1.5.
Perfect.
It should be less than 2.5, sorry, less than 2.5. And if it is more than 2.5 and you can do the placental growth factor, this can predict to a large extent whether this woman is likely to develop HDP, and you can put her on 2 rows aspirin. 150 is the recommended dose. One daily, one tablet.
Yeah, so
And
very
it
good.
gives you
On
list
ultrasound. Yeah. What else on the maternal characteristic, Dr. Ritika? Can you throw some light on this? On maternal characteristic, can you, predict that this lady is going to develop or hypertensive disorder of pregnancy? Yes, Dr. Ritika.
The patient, we should check whether the patient is obese or not. What was her pre-pregnancy weight, and what was the test what was the period? What was the cause for her infertility? And
so infertility itself is a high risk factor. She's undergone IUI. Then of course obesity. It must be her age, 36 years. 36. That is what I'm trying to tell you, that maternal characteristic right from age, BMI. Okay. So all these, points and history of hypothyroidism also, that gives you directly score 3. It's
Neha ma'am,
it's
can I speak
high
something?
risk. Yeah. So if you have the HDP
Ma'am.
general scoring, then of course this patient, you can easily find out and predict that this patient is likely to develop the hypertensive disorder pregnancy. And because we have the effective preventive measures of low dose aspirin and high dose calcium and vitamin D, definitely we can predict this. That is one. Secondly, when this patient, if at all you have screened her properly at 11 to 13 weeks itself, you would not have left her alone. You would not have told that everything is normal, correct? So this
Yes.
patient was supposed to be told that, you have to be in regular follow-up with, otherwise also for a normal pregnancy, we say that ANC care should be regular. Otherwise that itself
Yes.
becomes a high risk factor, correct? Okay, now when she comes to the PHC with 176 by 116, Dr. Ashwin, I will ask you. And Dr. Sapna, I can see you now. So both of you, I will ask you. What
Madam, there
is
is one
Yeah,
more risk factor. There is one more risk factor which you can diagnose by history. Ma'am, in IVF pregnancy, the frozen embryo transfer babies are likely to have
But no,
hypertensive this
we
thing.
will not discuss this, Monica. This is IUI.
Yeah.
This
That
is
is a
IUI.
IUI conception.
This is
For our
IUI
patient,
conception.
okay, yes. So IVF
Yes.
pregnancy is a high risk pregnancy and frozen embryo, yes. So now we are discussing this, that when she had 176 by 116, she was given only tablet nifedipine retard. So Dr. Ashwin, I would ask,
Yes, madam.
at that point of time, what should have been the treatment, whether this is right, nifedipine retard?
Depending on the ability and expertise, if the only medical officer is available, then nifedipine will be the right, because they have no expertise
not-
for injectable. And
No,
same time,
you're not getting the question. What I'm trying to ask is, for severe hypertension, it is not nifedipine retard. It is
yes, yes, madam. Yes,
Okay.
it is not retard. It is slow acting. Definitely, it is slow acting.
Okay, so
Second
that is
thing-
one mistake on the part of the doctor there.
Second thing, if they want to refer, it should be referred immediately with even prophylactic Mexalf. If the medical officer is trained for this thing, they have to refer with the Mexalf also. They little bit help in control of the blood pressure, as well as it also prevent the convulsion also. So that can be done.
Right.
Even
Secondly-
less 6 year, less 6 year. If they have predicted the complications, then even they can refer with less 6 also. So that will be help in both the way, prevention of this pulmonary edema as well as the control of hypertension.
There are so many other predictors also, so many things you could have done. Sapna, can you talk
Yes.
about this? When this patient was taken for cesarean section, we give preload, okay? Fast fluids, 1 or 2 pints. So that you have to restrict. That is one. One more thing is, when you give, the baby is delivered, you give oxytocin. So here you have, of course, she was a case of severe hypertension, a strict no to methergine, but then you have to give carbetocin. If at all you give pitocin, it has to be a very concentrated oxytocin infusion, okay? And the moment you deliver the baby, you should give Lasix, okay? Because third stage is the one which gives you maximum venous return and maximum load on the heart, correct? All of you agree to this?
Yes,
So
ma'am.
there were so many things we could have done as obstetrician, and so many things we could have done and save this, mother from all these complications. So definitely in retrospect, we have to take this as a challenge that yes, definitely few things have been missed, and that is why all these complications discussing gives you the assessment of your own quality of the treatment, and then of course it gives you a scope for improvement, correct? So this is how, whenever you have, all of you have discussed this cardiorespiratory arrest, the checking, giving the chest compressions, then checking for airway, breathing, circulation, all these drugs I have talked about it, even the nebulizer, steroids, just to see that if at all anything has gone into spasm, so that can recover. And then you go for the bedside investigations of ECG, XHS, echo, whatever is available. So we have already talked about whether it could have been prevented. So we come to a consensus that yes, there were lots of mistakes at many stages. It was missed. Okay, so
Sneha ma'am, can I just say one sentence?
Yes.
I've joined late. I'm Dolly. Right.
Oh, welcome, Dolly.
Sorry, ma'am.
I'm going
We
to
can-
hand over to you, Dolly. You
Sure, sure.
go ahead. Yes, and you
Uh,
start in case.
In the previous case, we could have also calculated the Gestosa score
That
to
we have
predict.
discussed, Dolly. That we have discussed already. Okay,
Okay.
right from age, BMI, and any other family history or personal history of hypertensive disorders, diabetes, any vasculopathy, renal disease, and thyroid. So I talked about thyroid, that it gives you score of 3 directly. Okay,
Yes, ma'am.
hypothyroidism. So
Ma'am,
I
can I-
go to you now for the second case.
Okay,
Ma'am,
ma'am.
can I please request Suvarna madam to please give her blessings? Ma'am has joined in
Madam,
spite of
good
her busy schedule. We welcome you, Suvarna ma'am.
Madam, good evening. Should I stop sharing?
Just, I won't say much because my voice is gone, so I was little
Oh,
hesitant in joining also. But I'm
Madam,
listening
please
to the wonderful.
don't strain so much. You just bless all of us.
Yeah, really. But I was wanting to tell you that the great discussion is happening, and I'm enjoying thoroughly, and I'm wishing you all the best. All of you are doing great job. So I just could not do any other thing than what I said just now. Thank you so much.
Madam, please take care. Take care.
Thank you so much, ma'am.
Bye, dear.
Thank you.
Bye. Thanks.
Take care, ma'am, and thank you for joining us in spite
Yeah,
of your
yeah. Sure. I don't like to usually miss commitment, but anyway,
Thank you.
thanks a lot. Bye. Bye.
Okay.
Dolly ma'am.
Yeah.
Go ahead,
So
please.
I'll take
Go
the
to you.
third case. I'm sorry for joining in late. So a 20-year-old primary gravida, 9 months amenorrhea, referred at 11 p.m. with history of admission at a nearby nursing home. At 3 p.m. with history of strong labor pains since 3 to 4 hours prior to admission. As there was failure to progress in spite of severe contractions, she was posted for cesarean section, bladder catheterized, no urine output, so she was referred to us. On examination, the patient was having severe pain in abdomen. Pulse was 110 per minute, BP 110/70, uterine contractions plus, severe in intensity, and almost no relaxation in between. Fetal heart was 100 per minute. PV was cervix 7 centimeter dilated, membranes absent, and vertex at 0 station. So what is the diagnosis and how do you manage? So can I ask Dr. Sapna, what is the diagnosis and how will you manage? We can't hear you, Dr. Sapna. Dr. Sapna, we can't hear you.
You are unmute now. Dr. Sapna.
Dr. Sapna,
But
please
we
go
are
ahead
not
now.
we are not able to hear you. Dr. Sapna, we are not able to hear you. There is something else.
So can you go ahead with it? We'll ask Dr. Sapna later. So what is the diagnosis and how will you manage? Hello? Yes, sir. You go ahead, sir.
Can I speak?
Yes, sir.
This is a case of induced labor, and most probably with induction complication like fetal distress with a hyperstimulation is more likely here, or it may be the case of misdiagnosis of contracted pelvis also. But here is the main, the fetal distress with the hyperstimulation is the main important thing. So immediate action is needed.
So what will you do? How will you manage?
Definitely the fetal heart sound is very low, so immediately we have to plan for the delivery of the fetus. And second thing, something word written in the textbook is the intrauterine resuscitation. So immediately first just stop the uterine contraction. We can use the injection subcutaneously, terbutaline, give the left lateral position, oxygen, and fast plain IV fluid that is ringer lactate. So that will be help little bit for the resuscitation of the baby before we deliver and whatever the emergency cesarean section. And of course, parallel we have to plan for the emergency cesarean section.
Okay. Any precautions to be taken in the cesarean section? What difficulty you are going to face in the cesarean section?
Yes. Here 7 centimeter induced labor. There may be the thin bulging lower segment. Second thing, bladder may be advanced. So on opening of the abdomen, we have to be very careful. Otherwise, we may injure the bladder. Second thing, the lower segment is thin and bulged, so extension is more likely. deeply engaged head, we have to expect at 7 centimeter induced hyperstimulation. So the delivery of the difficult delivery at the time of baby delivery will be expected. And of course, lastly, the postpartum hemorrhage or even traumatic postpartum hemorrhage, or it may be even atonic postpartum hemorrhage after delivery of the placenta.
Mainly traumatic postpartum hemorrhage. And what
Yes.
about the fetus? What about the baby? You will call the pediatrician or not?
Yes, must.
Okay. Any other panelists? Can they want to say something about it? Very well managed, sir. Dr. Sapna, now you want to comment upon it?
Sometimes there may be need to push the head from down.
Right. So how do you do that? What is the method of pushing the head from below?
I will tell my assistant by sterile gloves, gloved hand.
But then you have to take some precautions, right?
Madam,
How will you push? What precautions we take while pushing the head from below? Can anybody come up with that?
Yes, madam. The first, there are two options. Either we can push from below or pull from above. So, but the operator must be prepared before putting the incision on the uterus. If our planning is push from below, the one assistant must be ready with full aseptic precaution, panting wrapping. Then immediately sterile gloves and should be introduced from the below, and they have to push it baby head adequately from upward. And same time.
Sir, your voice. Sir, we cannot hear you. Your voice.
Patwardhan and modified Patwardhan methods and all these things. That is pulled from above. So if we are planning that thing, then our incision on the uterus should be little bit upward. So that will be immediately, once you put the incision on uterus, directly you come across the shoulder of the baby. So we can work in the shoulder and can deliver the baby.
Okay. The only thing is that while pushing from below, you have to take care that you should not fracture the skull. The pressure should not be excessive. And nowadays there are pillows available which can just push up the baby's head and then you can deliver. Otherwise, you can deliver by the Patwardhan's method, right?
Yes, correct.
Yes. Sneha ma'am, you want to comment upon this? Dr. Sneha?
He has a device issue or internet issue.
No,
because
I'm very much here. Don't worry. Okay, so you go ahead with the discussion. What is the diagnosis for this patient and what is your management? I got it. While LSAS, you're talking about pushing this. What are all these problems associated with this case?
As there is no relaxation, means there may be abruptio placenta. Maybe there. Intensity, severe intensity. Hello.
Madam, we are listening.
Okay. Sneha ma'am, can you just shift the slides now? Actually, the slides are with Dr. Sneha. Okay.
Yes. Sir.
So,
Yeah.
so there can be abruption and the problems can be, as we mentioned that it is an obstructed labor, there can be coagulation failure and there can be anuria as well. So the hemoglobin of the patient was 8 gram per cent. The platelets was 1 lakh. The APTT was prolonged. Fibrinogen was 150. FDPs were present. So how do you revise your diagnosis now? What will you do now? What is it now?
Arrange for blood.
Now it's a case of abruptio placenta.
Along with blood also, FFP and blood. And
coagulation abnormality.
Platelets are less. That's why platelet also.
We have to arrange the blood and blood product.
1:1 ratio, if that is available.
Check the patient blood pressure also. Again, why this abruption has occurred, we have to check it that also.
There may be sometime associated PIH also.
Yes.
And there may be associated. Following that, there can be PPH as well.
We have to check the function test because there is anuria, so we have to check the renal functions.
Renal functions.
Right. Okay.
Means she is a case now in early DIC.
Early DIC, yes. So what will you do now? How will you manage the anuria and the coagulopathy? You have also already mentioned about the coagulopathy. What will you do for the anuria part?
For the anuria part, we will first investigate on the renal function test, give her the fluid therapy. We have to check whether with the fluid therapy, the urine is coming out or not. So if the patient is
Whether you
responding
will
with the
do the renal function test first and then you will give the fluids, how? Whether you will wait for the reports?
No, we can give the
simultaneous
report will come.
No, the reports will take lots of time, maybe. But what we have to do is, because the patient has landed up into acute renal failure,
we have to give the fluid
we need
therapy.
to and because we don't want her to go into irreversible renal failure, that is acute tubular cortical
Yes, ma'am.
necrosis. Okay, so we
So
have
if
to
the
correct the hypovolemia first.
yes,
correct?
RS is clear, then correct the hypovolemia first.
But-
And give the Lasix when RS is when the intravascular volume is restored, then we can give the
fluid
Lasix
challenge.
challenge.
Okay, you give
Yes, Lasix.
fluids and give Lasix so that the circulation improves, the hypovolemia improves, and then of course, when the renal perfusion improves, she passes urine. Okay, go ahead, Dr. Dolly, my dear.
Yeah. And if this patient is after you have managed all this thing, and if you have shifted the patient to an HD unit, how will you monitor this patient? What will be the post of monitoring of this patient?
We have to check this patient for the postpartum hemorrhage because she has the abruption. So there is a high risk of PPH also. And the most important, her renal function, that she was not having the urine. So that has to be monitored later on. And proper monitoring of the complete blood count, because she has a hemoglobin of 8 grams before surgery. So we have to monitor that.
And what about the CVP monitoring, because she's into anuria and we are giving fluids?
Fluid should be given as per the CVP monitoring.
Yes, that is what is important. That fluid resuscitation has to be done. If the patient is in ICU, then the fluid resuscitation has to be done by CVP monitoring. Okay?
And also we have to repeat the coagulation profile.
Right.
If it is grossly deranged, then we may require most of the time in abruptio placenta. Once we deliver, then a coagulation become gradually reversed. But sometimes it may persist, and if grossly deranged, then we may require the component transfusion again.
Yes. And if here the fetal heart was 100, so we planned for a cesarean section. If in this moment, if the fetal heart becomes absent, then what will you do in such a case?
Then we have to assess the cervix. Here it is 7. I think here it is a 7 centimeter dilated. So we have to assess from the below. If the delivery is imminent, then definitely we have to go for the vaginal delivery. Once there is no questions of the fetal life, then we can go for vaginal delivery. But if the cervix is not properly dilated and we think that it takes much time, then definitely again seizure I recommend the seizure.
Because we are suspecting an abruption and coagulopathy. So we have to take a very, very important decision whether we should go in for a normal delivery or directly for a cesarean section. But if the fetal heart is absent, then we can give a trial of normal delivery, right? Okay, fine. Take it. That's fine. So what about the management? We have already discussed that you have to restore the volume. You have to manage the coagulation part. The coagulation factors have to be restored. The hematocrit has to be checked, and then even the electrolytes have to be checked. So we have to respect that the urine output should be more than 30 ml per hour, right? And the fluid resuscitation has to be done according to the CVP monitoring. So 2 large bore IV cannulas are inserted and the blood sent for cross-matching and investigation, particularly for the coagulation profile. Oxygen supplementation and blood components are the most important aspect of the management of such a patient. So case number 4, a 32-year-old, madam, are you taking? Sneha ma'am.
Yes. Now I will take this case. This is, has Dr. Amrita joined? I think she was having some emergency PPH or something.
Ma'am, she is not yet free from the OTD.
Okay.
Yes, madam.
Who else we have? Do we have any other panelists to be answering?
Yes, madam. I am there.
Yeah. Apart from
Dr. Ashwin,
yes. Who else we have? Do we have anybody else? Dr. Gauri, is she our panelist?
Ma'am, Ritika madam is there. Dr. Sapna Kasi is there. Pratika madam.
Sapna. I think she has discussed this case, no? So we have, we'll go to Dr. Ashwin. We start from you. We have this
Yes.
32-year-old previous cesarean section. No, she's 32-year-old patient who is para 1, and she's had a previous seizure 1 year back only. She's got a male child. Now she came to you directly during 6 months of her pregnancy with history of bleeding, and she came to you for the first time because she got transferred. Her husband got transferred here. Okay, so when you ask her in detail, she gives you history of spotting during early pregnancy when ultrasonography was done, and that was reported to be low-lying placenta. Okay. Now, because she has bled, and of course, she has come to you for the first time. When you do her ultrasonography, you find that it is 26 weeks. Anomaly scan is normal, but the placenta is low-lying and it is previa. Not only low-lying, but it is previa with absent retroplacental lake. So then she was, given medicine and she was sent home. At 30 weeks, again she comes to you with history of bleeding, and by the time she reaches hospital, so now there is no active bleeding, so you thought of getting investigated. So but during the investigation itself, she collapsed in your hospital only. How would you manage this patient?
When the patient collapses, then immediately we have to start the resuscitation. Of course. Second thing, she is a diagnosed case of placenta previa, and probability of the even with previous cesarean placenta on the scar and with absence of retroplacental shadow, so it's more likely to be the even placenta accreta spectrum, that is PASS.
Correct.
And the bleeding
management now. What is your plan of management? 30 weeks previous seizure, bleeding and collapsed. So you will
once the collapse,
okay.
Yes, resuscitation, and once such diagnosed case with collapse, then definitely irrespective of the gestational age, we have to go for exploration. That is cesarean section.
Okay.
But only thing, we have to be very well prepared for.
What will you tell the patient? How will you prepare yourself? Tell me. What
Yes,
all the things?
We emergency resuscitation, call for the blood. Even we give the call to the blood bank. She may require the even massive transfusion. So the arrangement for the blood, and call to the senior, because on table we may require the senior most person available in the institute, because this is a case of PASS.
Your team is managing the patient. You have your anesthetist friend now in front of you. He is helping you in managing the patient, keeping the operation theater also ready. But what will you talk to the relatives for this?
Yes, same time we have to continue the dialogue with the relative that this is the diagnosis, condition is this, criticality is there, but definitely we have to go for the surgery.
How will you talk about this patient?
I will talk with the relative that there is a previous cesarean section, currently previa, suspected accreta. She needs the surgery, but same time it is critical. She needs the multiple transfusion. She may need the even obstetric hysterectomy, irrespective of the current baby outcome. She may even she may have the on-table injury to the bladder or ureter, and we may require the even expert person to repair the bladder also. And not only this, multiple transfusion and excessive bleeding may lead to the need for the ICU admission, ventilatory care, and all these things.
Okay,
and
that is all about the mother. But what about the baby? What will you counsel them?
Baby is a very preterm, but we have no option. So baby, we will try our best, but require the NICU admissions and all these things.
Yes. In spite of all this, we may not be able to. We may not assure about the
yes, 30 weeks.
Baby, but we have no option but to go for cesarean section. There cannot be a conservative management when the patient is bleeding in front of you, collapsed. Okay, so there cannot be a conservative management, right? Now you tell me that when you try and resuscitate the patient, you arrange for blood and blood product. Now your anesthetist friend is there. You are planning to take the patient in operation theater. Your team should comprise of how many people, who all you want with you?
So one thing is, if you are in the small nursing home, then I even prefer in such cases 2 anesthetists, so that they will take the proper care of the patient and transfusions and all these things. And in our team, we at least 2 obstetricians. Even though we are in the private, we may prefer to call the someone else for the proper assistance, so that it will be helpful. And depending on expertise of the gynecologist, if you are expert in handling the bladders and all these things, there may be the rupture uterus, there may be the pus, there may be the injury to the bladder. You are expert, then there is no problem. Otherwise, you have to call the one person that can handle to such a urological problems also.
Okay, so one is obstetrician, senior obstetrician you want. You
Yes,
want
yes,
two
madam.
anesthetist or a senior anesthetist. Okay.
Yeah, yes.
And you want the neonatologist with NICU arrangement, correct?
Yes, ma'am.
Yes. And then you want
And
blood product.
blood bank to inform that we may require the massive transfusion and components.
Yes. And also you want the
We have lost the sound.
Hello. Yes, sir, you go ahead. So, for the blood components.
Sneha madam's voice is not there.
Okay, sir, but you go ahead.
Okay. Blood and blood component. Here we are expecting the massive transfusion may required. So directly from the massive transfusion protocol, because we cannot wait for the even coagulation profile also. So here we can directly go for massive transfusion protocol. 4 unit RCC, 4 unit FFP can be given in first round. And further if transfusion needed, we can add the even platelet also.
Okay, fine.
So 1-to-1 at least starting from RCC plus FFP.
Yes, but you have to be careful regarding the aspect of trolley also. You have to take care of that aspect also. That you should give blood whatever is adequate.
Yes, 2+2 we can start and we can preserve another 2+2.
Yeah, yes. So, what precautions are you going to take while doing the hysterectomy regarding bladder is concerned?
So once our diagnosis is passed and once we have decided to go for the surgery, and another thing, ideally such case should be evaluated before starting the surgery also, but we have no time in this case. So whether it is placenta, simple accreta, whether it is more likely to be increta or percreta, if clear-cut evidence and reliable reports are there, it is a case of placenta percreta, then definitely we have to plan for the obstetric hysterectomy directly, irrespective of the obstetric status and all these things. So in this situation, I prefer to open from little bit upper incision, that is upper classical incision, and deliver the baby.
You are going to give a vertical incision or a transverse incision on the abdomen?
Abdomen depending on the expert. If previous incision transfer, then we are now accustomed with the transfer. But the book says that vertical incision is preferred in terms of. But now we can do the fast even in transverse incision also. Even we can do the muscle cutting if needed. So personally, previous transverse incision, then I prefer the transverse in abdomen. But in uterus.
But where, sir, Dr. Ashwini,
yes,
wherever you are planning an obstetric hysterectomy, it is better to open with a vertical incision, because then you have to do a classical incision on the uterus. That would be better.
Even with muscle cutting, we can have the adequate space and we can give the classical incision on uterus. But our purpose on uterus, it should be classical one without disturbing the placenta at the time of delivery of the baby.
That's more important, that you are not going to disturb the placenta and go ahead with your obstetric hysterectomy.
How will you take the incision on uterus? What you are
ideally,
yes.
Ideally, madam, we have to do the placental mapping before starting the cesarean.
Yes, perfect. That is what I want.
Yes. If the placenta is,
it's not only the classical or vertical, but you have to see to it that at no point of time you are reaching the
sometimes just anteriorly placental bulk is less, and just we have the adequate space, and then the higher up transverse incision on uterus may work. So that is our placental mapping is must. Ultimate aim is we should not disturb the placenta at the time of delivery of the baby. Otherwise, your field will be the messy, severe hemorrhage, patient may go on table on shock. That is our key message.
And not only your field will be messy, if you cut the placenta, then you had it. It will be torrential bleeding, because unless you control it, unless you remove the uterus, then only it will stop. So you have to take care that you map the placenta and you just short the placenta. You have to stop. Okay. Otherwise, you go for ideally the transpondal. If you find it is little higher also on this side, then you go for transpondal, that is transverse incision high up. Correct? Okay.
Yes.
What we have talked about the team. I was talking to you about the team. What team you should have. In addition to all this, anybody else you want with you? If you have the facilities available.
Yes, interventional radiologist, madam.
Yes,
If we are lucky and in the corporate, then
Mhm.
we may have the backup of interventional radiologists. They may be helpful. But frankly speaking, most of the study, there are little evidence that before starting the cesarean, we can introduce the catheter or balloon in the vessels and then block. But definitely post-operatively, if the excessive hemorrhage is there, we are not able to control, then it will be helpful.
Okay. So nowadays people are saying that, intervention, if you embolize the uterine arteries before going for all this surgery, and there is also a surgical option of stepwise revascularization. In
Yes,
this
madam.
situation, when you just deliver the baby, try, if you're sure about your diagnosis, try not to touch and pull the placenta. Just, clamp your uterine edges, cut edges with your clamps or green arbitrage forces, and then you go for devascularization, and you just remove the uterus, clamp, cut, remove. That's all.
Yes.
You need not ligate and transfix and waste time in that when the uterus is bleeding profusely, right?
But one more thing I can add, madam.
Yes.
In such situation, mostly in centrally bladder is densely adherent and highly vascular. So what I prefer, you have to go from the lateral window.
Yes.
You start the separating the bladder from the lateral margin on both the side and gradually go inside. Sometimes what happens centrally, we are not able to separate the placenta initially, but laterally we have the enough window and we can take the uterine. That's what you have said, step-wise devascularization.
Yes.
If you take the both side uterine before starting the thing, then probably on table we will minimize the severe blood loss.
Right. Do we have Dr. Vaibhav Nadkarni as our panelist? Do we have Dr. Vaibhav Nadkarni? No. Monica, do we have Dr. Nadkarni here? Ritika Gupta, I can see. And Monica Singh, is she there?
Yeah, she's there, madam.
Yeah. Hi, Monica. I don't think she is active. Okay. So I think we continue with Dr. Pratibha Chauhan and Dr. Sapna. Okay. So,
Madam, I'm there. Madam, I'm there, but I'm
Okay.
in one little meeting, madam. But I'm there. I'm there in the webinar, ma'am.
No problem. Okay. So, in addition to all this, suppose this patient is a suppose this patient is a multigravida, but then she's got only one child, 1 year old. Okay. And this child is, you are not sure. So she insists that, I don't want to remove the uterus. I want to go for uterine conservative surgery. Any choice for this patient? Monica?
Again, that depends upon her vital condition. If she's stable, we can left over the placenta like that only and close the uterus, and that is one of the choice. But there are again chances of infection, septicemia.
No. We don't, I mean, the evidence doesn't support at all. Leaving behind the placenta is now out of question. Previously, even we have done many cases, maybe long back, 3.5 decades ago, 35 years ago, but not now. Okay. So evidence doesn't.
Can I?
Yeah, please. Who's that?
Can I add, madam?
Yes, please.
There is some popularly known as the modified triple P procedure, if I am not wrong.
Yes.
So in which we doesn't disturb the placenta in initial stage, and then we do the pelvic devascularization by separating the bladders from laterally.
So what is the triple P? What is that triple P? What is the
first P is placental mapping.
Perfect.
So our purpose is not to disturb the placenta at the time of delivery of the baby. So that we have to do. Second P is pelvic devascularization.
It is
So
step
in
wise.
original,
Step
by devascularization. That is in modified triple P step by devascularization that everybody can do in small setup also. But original triple P procedure, they have used the interventional radiology that is started in the London hospital first. So that is pelvic devascularization. And then we can go with the gentle placental separation. Third P is the gentle placental separation.
That is what is called as, that P is patchy resection.
Yes. And usually we have to start from the posterior wall where we are not expecting the adhesion or adherent placenta. then gradually come to the center, and lastly come to the anteriorly. And those portions which are adherent or infiltrating to the lower segment, we can cut the strip of that uterine along with the placenta. So that
Yes.
is removal of
That
the
is
strip
called,
of the
that
lower
is why it
segment.
is called as patchy myometrial resection.
Yes, yes, madam.
Okay,
Exactly.
okay.
Yes,
So
madam.
this is one option which was present even when we were discussing about the elective obstetric hysterectomy. This procedure was there, but if you are well
Yes,
prepared
madam.
with everything, you can go for. But nowadays we are changing our concept because we have many people nowadays, they are doing hundreds of procedures they are doing on uterine conservative surgery. Okay, so you have that Comog MG stitch. You have to go. I'm sure you must be knowing about it, and people are doing it nowadays. Hundreds of patients they are doing it. That when you before touching the placenta, you do the devascularization, and in addition to that, you take a cervicoischemic stitch. Okay,
Stitch,
so
yes.
that you along with the internal iliac and ovarian and uterine vessels, you also go for ligating the descending cervical vessel. So ischemo-cervical stitch you have to take, that is Comog MG, Mahesh Gupta stitch. So in that, when you find that everything is stable, if the patient is stable, definitely you can go for this. And then of course you can go for what you have described, the patchy resection. Slowly you remove the placenta, and definitely there is absolutely no need for this taking stitches in the placental bed. It will worsen the condition. Okay,
Yes,
we
madam.
just
Yes.
give a compression that will help. That is how it is now. The uterine conservative surgery, I'm sure there is lots and lots progressing or advancing in this field. You have what is called as the Pilley's aortic clamp. It's like this, C-shaped. So it actually occludes the aorta at its bifurcation when you have the common iliacs, and so at the bifurcation you can apply that Pilley's aortic clamp, or you may have that aortic balloon nowadays. People are putting aortic balloon before the procedure and reducing the blood supply. And then of course you have the uterine artery embolization and so many other things. So uterine conservative surgeries are on a rise. People have been successfully doing all these surgeries, and I think we are able to. Maybe you really need to have that courage, and of course that expert hand you have to have for doing this procedure. So unless you have many cases witnessed, assisted, and yourself done yourself, I'm sure nobody will dare to go for such conservative surgery. So now that our patient has passed through all this catastrophe, my question comes to you, all the panelists. I think right from Monica Singh, I would say, Monica, was this preventable for our patient?
Ma'am, Dr. Monica is not there around now.
She is seen, and she will. Yes, Monica, this is a case of placenta previa accreta. So could this have been prevented? What catastrophe she has to go through?
Yes, ma'am, it could have been prevented, this catastrophe. The management of the third stage of labor should have been more stringent.
No, my dear. We're talking about placenta accreta spectrum, where she has collapsed. I think she was not in touch. Sorry, Monica, we exclude you for some time. And
Yes, ma'am.
I would ask Dr. Pratibha Chauhan. Pratibha?
Yeah, during she had history of spotting many times. There was need to admit her and complete rest also. She might now not have taken the rest, and multiple times she had episodes of spotting and bleeding.
So yes, so
Can I add, madam? Can I add?
Yes. So she was having placenta previa. That was the early pregnancy report. Then of course she was having the absent RP leg. So the message here is, whenever you have a patient of previous seizure, even during early pregnancy, especially ask your sonologist that whether it is a low-lying sac.
Yes.
Okay, whether it is a low-lying pregnancy sac, or it is close to the scar, whether you have that myometrium interface free, whether you have the retroplacental sonolucent zone intact or no. Secondly, if miss see, people are saying that if you diagnose it as very, very early pregnancy, people are talking about, termination of the pregnancy, because when by this time it has not encroached deep inside the myometrium. So, but then again, there is a question mark that in such situation, even for MTP, she will bleed profusely, correct? So
Yes.
I personally do not agree to this point that we can advise the termination of pregnancy, though there are lots of discussion and debate on this. But when you continue this pregnancy, when you go for the anomaly scan at 18 to 20 weeks, that is the best time for confirmation whether you have the retroplacental sonolucent zone intact, or whether you have multiple sinuses running into the myometrium, placental sinuses running across the bladder, so those laminae, you have high flow, laminar flow, everything you have to take, watch for. You have to ask your sonologist specially for this. Every time when I have a patient of cesarean, previous seizure, I ask them, please look for it that this is not a morbidly adherent placenta. If you find this, the moment you find this, you label it. You label her as a case of placenta previa accreta, and then you advise her so many things. Okay. So in that, do you advise prophylactic or straightening?
No, no, no.
No, madam. No,
A
madam.
strict no. A strict no. Do you advise
No.
a lipolysis?
No.
No.
No, because there are no contractions only. Why do we want to give relaxant, right? So nothing is going to help. So this is unindicated. What you have to do is only advise for the, whatever precautions that, she is a case of high risk pregnancy. She can bleed anytime during pregnancy. So absolutely no to intercourse, absolute no to internal examination, and of course the strenuous work. She should not travel also. She should not run around. She should not have any strenuous work. And with everything understood, she has to either, if she is close to the hospital, then only a domiciliary management. Otherwise, preferably, she has to be hospitalized. Blood has to be kept ready, right? And in spite of all this, yes, anybody wants to say, in spite of all this, you have to tell the relatives and take an informed written consent that this is placenta previa accreta, nothing is in our hand. In spite of
Yes.
everything being ready, she can, land up into complication anytime. She can collapse anytime, be in the, pool of blood anytime. So whenever she lands up into problem, we have to intervene and go for emergency operative procedure and all these complications. So these are the Green-Top guidelines, which I have talked about, that at 16 weeks, you look for the low-lying placenta, 18 to 20 weeks, you label it, go ask her to follow all these guidelines. But at 32 to 36 weeks, you confirm your diagnosis once again, even when it was labeled. So during this period, what do you do?
Remember,
Ritika, yes.
if the patient has crossed the 28 week, we can offer her the antenatal steroid for the fetal lung maturity and the and the Maxelf also for the neuroprotection.
Perfect. That is what the message we want to give, that whenever you have a high risk patient being conserved, you want to pull her till salvageability, but you don't know what time she will land up into complications.
Yes.
And that is
So once
the role of antenatal steroids comes. Yes, Dr. Ashwin.
So once 36 week is completed and we already labeled as a pass, then we should plan the elective surgery at 36 week. Don't wait till up to the term.
Yes, that you have to take the discussion ahead, that when should you plan the cesarean section.
Yes,
Some people say 34 weeks. Some people say 34 weeks. But I personally feel that 36 weeks should be okay. But at any time you feel, that's the reason there comes a role of measurement of cervical length. Okay. So if you find that the cervix is short, then you have the prediction of preterm labor also. That means the lower segment will be formed earlier, and that is where comes the role of cervical length, where you can predict that maybe we have to take her for cesarean section earlier before she bleeds, right? So otherwise, if cervix is long enough and there's no formation of lower uterine segment, then you can maybe try and pull her to 35 plus weeks. Okay, that is what the message is. And then of course, meanwhile, you have to, as you have rightly pointed out, that it should not be taken as an emergency. In fact, it should be posted as a elective procedure. So what is the reason for this, Dr. Pratibha and Dr. Ritika? I will ask you, both of you. Why we have to keep this as a
Because we have to arrange for the blood product and need
Expert.
other help. Other
Basically, we
people.
will get a lot of help if we are doing in the elective time. We will get lot of
We'll
help.
get,
Our colleagues help, our seniors help. So that will be the helpful for the patient. And if it at all we needed to shift the patient from our hospital to any multi-specialty hospital, whether the ICU facilities is available, it would be easier if we do it in the elective time.
And so time for the relatives for prepare their mind.
Yes. So first and foremost, you are preparing the patient and relatives for all these complications and procedure also. But then they have, during daytime or morning hours, the senior obstetricians, senior surgeons, everybody is awake.
Staff availability is also.
Right? And then, of course, the blood products, all these things. So whatever help you need, maybe even the radiologist, the surgeon, neurosurgeon, rather than calling at 2 a.m., better to invite them, for the elective procedure. So that is what the logic behind, that you have to take care of this procedure as an elective procedure. And one more thing, even if you are expert in the uterine conservative surgery, maybe you have done 10 procedures and you have succeeded in uterine conservation, the consent which you have to take is, it has to be a obstetric hysterectomy. Now, why so? Because why so, Dr. Ashwin? Please let me know.
Sometimes we do the step-by devascularization. We try to conserve the uterus, but it may not be the effective and bleeding may be there.
Yeah.
So at that time, rather than closing the uterus and rebleeding after 1 hour re-exploration, better to go directly for the hysterectomy. So on-table decision is final.
Yes, no, not on table, but then I would say that you have to prepare the patient and relatives. And here the reason being, sometimes if the relatives have not understood this procedure properly, if you have not counseled them, once you are doing the cesarean section and then you come out or call them inside and you say that because to save her life, we have to do obstetric hysterectomy, they will feel that, you have done something wrong. Right?
Yeah.
So you have to make them understand that this is a procedure. Even before we start the procedure, we are telling you that whatever precautions we take, she is going to land up into obstetric hysterectomy. We are going to try our best, but I don't assure you that we will be able to save her uterus. We have to save the patient. Okay. So that is what the medical legal aspect for this. And then this is a theoretical discussion. Who was the high risk for, this placenta accreta spectrum. Now this is about the blood and massive transfusion protocol. How should you initiate? What all the factors? I don't think we should go into. Only thing is, if somebody can talk about massive transfusion protocol, how do you initiate and what all things in what proportion?
So 2 things, madam.
Yes,
if we expect that we need the more than 4 units of the transfusion, then from very beginning we have to start is 1:1 protocol of the 1:1 proportion of the RCC plus FFP.
Okay.
One more thing, if you have done the surgery for any surgical cesarean for the already we are expecting the coagulopathy like severe abruption placenta and all these things.
Right.
Then again it should be from the very beginning 1:1 protocol. And if we crosses the more than 8 transfusion and again we want to continue the transfusion, then platelet should be added to this. So 1:1:1 should be there, the RCC, FFP and platelet.
Correct. So that is what you have to, take care of. You have to always keep a watch on, and you have to monitor in between that, how is your coagulation profile like. So
yes, sir.
Yeah, should we continue with the next case or should we stop here? Monica?
Ma'am, we can continue.
Okay. So Ritika, this is a patient for you, a grand multipara. She has admitted to the emergency ward at 11 p.m. as obstructed labor. Okay. Her vitals are good. BP is also normal, nothing. Only she landed up into obstructed labor, maternal exhaustion, and there is a thick meconium stent liquor. So with antibiotic cover, good fluid resuscitation, that means fluid preload, she was taken up for cesarean section. The cesarean section was also uneventful. It delivered a 4 kg baby. There was a little extension on one side, but there was no bleeding. That extension was also repaired, sutured very carefully. The patient was shifted uneventfully to the ward. After 1 hour, the patient suddenly, started sweating a lot. The pulse became thready, with disturbed respiration, confused look, and she had a vomiting tendency. So on examination, there was no pallor, only the BP was going down 80 millimeter. There was no bleeding. Internally also, the abdomen was soft. Externally also, there was no bleeding. The uterus was well contracted. What is your diagnosis, Dr. Ritika?
Ma'am, as this patient is a grand multipara with a difficult labor, as she has a obstetric labor, then she underwent for the cesarean section, in which we also have a trauma to the uterus, which was repaired well. And the patient has now presented after 1 hour with the shock condition, with the blood pressure 80 and the 3D pulse, with the disturbed, difficult breathing. We can say that labored breathing. So the first thing, the patient is in a shock at this time. First thing which come in our mind is the PPH, but in this case there is no evidence of PPH. So next things that come in our mind is that it may be the case of embolism. So first of all, we would like to resuscitate the patient. The most important thing is the
yeah. So how will you resuscitate this patient?
Yes, ma'am. Most important thing, the resuscitation is the check the patient. First of all, the patient ventilation. Maintain the patient ventilation at the patient has blood pressure of 80 and the 30 pulse, disturbed respiration. We would like to check her SpO2 level. What is her saturation level? And if it's falling, we have to give the high flow oxygen. With the shout for help, we have to involve our critical care specialist in this case.
Dr. Ritika, I'll just stop you here because you have said, okay, all of us know that, and you have also said you have to resuscitate this patient. She's already operated, she's on IV fluids. You want to increase her IV fluids?
Yes, ma'am, we would like to increase the IV fluid.
What else? What is the reason? I mean, how will you do? She's already receiving IV fluids. People are saying that she's receiving at a good rate and things were fine. Urine output also.
Electrolyte imbalance may be there in this case.
We have to check her the arterial blood gas analysis immediately. That will help.
Inotropes you have to start immediately.
We have to check her saturation level. If it's falling, we have to intubate the
Before
patient.
Before going, see, basic things that you start your IV, give her oxygen, but then what is the what is the diagnosis? Unless you know the diagnosis, how you are going to treat it?
So we are suspecting the case of amniotic fluid embolism in this case.
How do you do that? But then,
Madam,
let me talk that amniotic fluid is a diagnosis of exclusion.
Yes,
and that's even a postmortem.
So all the possible differential diagnosis should be kept in mind. One is amniotic fluid embolism, even pulmonary embolism, or even a cardiac condition sometimes which is not diagnosed before and that may be manifested. And even biochemical.
Even electrolyte imbalance may be there.
Even electrolyte imbalance or even diabetes or hypoglycemia or hyperglycemia.
That is why I am saying you are coming. Don't go very.
Diabetic ketoacidosis may be there. Diabetic.
So
because her baby is 4 kg.
That is what I'm trying to tell you, that what bedside test you can do. Do her blood sugar.
Urine sugar.
Yes, ma'am. It's a blood sugar.
Blood sugar.
Do her, even on glucometer you can do. The sugars are very high. Urine sugar 3+, urine ketones 3+, 2+. So this is a case of diabetic ketoacidosis. Why I have included, this is a very interesting case actually happened. And this is from Gujarat only, and that patient has filed a suit against the doctor, and Dr. MC Patel always talks about this, though we had a similar patient. So here the message, this is just a message I'm giving, because I'm sure now all of you will call for help. Your friend will come and manage the patient, give insulin, bolus and infusion and everything. But the most important message here is every woman during every pregnancy should be screened for diabetes or hyperglycemia, right? So the moment she comes to you in your hospital for first antenatal checkup, you have to go for what is called as OGTT or 75 gram single test, glucose challenge test. So that is how. Now of course, you have to monitor this patient. You have to correct her hypertension, hyperglycemia. You have to give her insulin infusion, bolus first and infusion. You have to avoid the dehydration. This is called as, aggressive resuscitation, aggressive fluid resuscitation. Okay, because this patient lands up into dehydration. That is why she lands up into diabetic ketoacidosis.
Ketoacidosis.
Okay, and that is why you have to be very, very cautious. So see the amount of fluid they're giving. 75% of the fluid deficit has to be done during first 24 hours. And that is how it is calculated. Initial fluid is 0.9%, the first 1000 ml per hour for first 2 hours. Then of course over 2 hours you have to give the normal saline as 250 ml per hour. Okay, and then you slowly see that she's recovering, her glucose levels are less than 200. Then you have to come to the routine management. Okay, so this is what the IV bolus of 15 units of insulin itself, and then you have to monitor it giving as infusion. That is how you manage it. But then if you have your physician friend at your service, definitely you don't have to learn all this. But I think you have to be ready and see what actually you can do to prevent all these catastrophes. So such a simple test. We're getting lots of noise, I think. Such a simple test of, a screening test for diabetes that somebody, if misses, the patient can land up into this severe catastrophic condition. And that is why, friends, you have to be very, very cautious. See that all your patients you screen for the common disorders, okay? Anemia, hypothyroidism, diabetes mellitus, hypertensive disorders of pregnancy. Then of course you have that thalassemias and all those conditions. Certain catastrophic conditions of thyroid as well as liver, that also you have to rule out. But these are 3-4 basic conditions where once you screen the patient, you will definitely save them from all this catastrophe. So don't say that I will refer this patient to physician, because in this moribund condition, you are not allowed to refer the patient. She can die on the way itself. And that is why every obstetric unit and every person of the team must be trained and skilled to manage the maternal collapse. There's no time for immediate referral, and referring such a person is a crime. You should not do that. So the team should be able to manage effectively then and there only. For this, we should have an efficient multidisciplinary team, not only HDU. So it's not it's not HDU, but the manpower, the staff, yourself should be trained for all these obstetric conditions. So friends, with this, I conclude my discussion. And I thank all of you for, very interactive panel and your inputs. I thank my dear friend, Dr. Dolly, for the, being associated with this panel discussion, moderating with me, taking care when I was disconnected. So thank you so much. And I humbly make an appeal to all of you to support my candidature for FOGSI Vice President for the upcoming elections. Friends, I was a FOGSI Breast Committee chairperson for 2 years. I was a governing council member for ICOG, the academic wing, and I'm a common obstetrician, practicing obstetrician since last 32 years. So I deserve your support and wholehearted support and your vote as well. So with all your support, I wish to go ahead. So please support me and vote for me. With this, I stop share. And if at all you have any queries or anything to be discussed, please let me know.
Madam, it was a fantastic panel, ma'am.
It was a great panel, having lots of practical tips. It was a very interactive and a great panel. Thank you so much, ma'am.
Thank you, Ritika.
Thank you, ma'am.
Thank you so much.
Yeah, ma'am, it was an excellent panel discussion. And Dr. Dolly, thank you very much.
I'm so sorry I was absent in between because I had a serious patient.
No,
Yes,
we all
madam.
understand.
It was very nice.
You are just
Though
discussing
I was
these things.
enrolled in the last moment, but I enjoyed it.
Yeah, thank you so much.
Yeah, thank you so much.
Thank you so much.
Purposefully, we select the cases which all of us face day to day. I just shared with you that even I was so relaxed and enjoying the program, but then I had a patient who, developed a reaction to the ferric carboxymaltose, which we are using in and out, So it's, but then we stabilize her immediately with minor reaction actually. So that is what obstetric is, and we are so well versed and so well prepared that we can take care of ourselves and we can take care of our patient also. So with this, I thank my expert, our dear friend, Dr. Archana Dwivedi. Also, Archana, we would like to
Yes,
hear from you 1 or 2 comments. You can make your comments as well.
Madam, actually, I think it was a learning experience. We do it daily, day in, day out. I'm at a tertiary care center, but with such a precision and some points which were given by Dr. Bachani, Monica, and everybody. I mean, it was very good, and I would appreciate that you took such important cases, which is day-to-day scenario, especially the placenta previa cases, and there were so many myths were solved. I think it was a learning experience, nothing to add, but it is like I have been your panelist also in past, done so many things with you. So I remember very, very apt and day-to-day OPD cases. And believe me, Dolly ma'am, you joined a bit late, but whenever you joined, it was like a bang only. We got good inputs from you, especially thinking about Charlie, what you said when you are giving passive transfusion. That was a very good take-home message, I would say. So
Thank you,
nothing much.
ma'am.
I think we all are doing so good. Expert. I mean, everybody's expert out here. And just give us blessings. Monica is here. I'm there.
Yes.
For the upcoming elections. I am coming for the Midlife Management Committee. So looking forward to your blessings. I know everybody is together, well knit, but still.
Best of luck to all of you
All
for
the
coming
best.
election.
Thank you, madam.
In
And
the
one word for Monica. Matlab, she is, I know, excellent. We have done so many webinars, but the precision and dedication what she carries is something commendable, Monica. Thank you for including me here. Thank you, ma'am.
In last, from PAC committee, I thank the chief guest, Dr. Jaideep Das sir and Veena Acharya madam, guest of honor, Suvarna madam and Alka Singh madam, and our esteemed speakers, Lakshmi Shikhande madam and Dr. Gaurav, our chairperson, Rashmi Khair, Deepa Masant and Swati Bhargav, our excellent moderators, Sneha madam and Dolly madam, and our expert, Archana madam, and all the panelists who have joined, and our PAC team, Dr. Priyankur, Dr. Monica, and Dr. Shatabdi, and Dr. Vadehi. I really am very highly thankful to everyone who has joined and made this program successful. Thank you very much. Good night.
Thank you so much. And
Thank you so much. Sorry, Sneha ma'am. Sorry.
No, sorry, my dear. No, sorry. We are together. So often we are moderating it also together. We continue to go ahead. No worries.
Behalf of Surat Ops and Gynec Society, I invite you for the upcoming presidential conference at Surat. 5th, 6th, and 7th.
Come in large numbers, please.
Thank you so much,
yes,
Dr.
please join
Ashwin.
with us.
I'll be very happy to join the conference. I have already talked to Dr.
Yes,
Monica.
yes, madam. Your name is came for the faculty also. We are adjusting.
Yes, thank you so much. I'll be very happy to join your conference. And Monica Gupta from Alwar. I'm coming to Alwar. I have been already invited.
Ma'am, we are waiting for you for last 2 years.
I know, but I will not make any excuse now, and I will 100% join all of you.
Madam, can I put a word here? We have the vice president. We have the vice president West Zone conference in Bhopal on 12, 13, 14 July. I know they are very close together, but this is the best conference. So we are looking at 1,000 registrations now, and this will be the best conference before elections. So I request everyone, please come to Bhopal and enjoy the City of Lakes. We will provide you the best academics and the best hospitality.
And Monica, I assure you from your side that Bhopal is a very nice place, madam. There is a very good place. Bhojpur also, you can visit there. Very big sibling and very nice place.
It is the heritage site. It's the WHO heritage site of Bhojpur temple. This is the biggest Shiv temple, very archaeological site. And then we have Bhimbetika, where the Pandavas used to live in that cave. You know, Bhimbetika has got that ancient man carvings. It's very MP, Pachmadi, Pandavas used to hide in the cave. So we've got lots of historical places around.
Good.
So Monica, we are coming. We are coming to you.
Please.
All
I'll be
the very
so
best to Archana and Monica Singh also. So Thank you so much, all of you. And please, all of you, please do remember Dr. Sneha Buyar.
Yes, ma'am. We always remember
And
you.
you are in our heart. We can't forget you.
Very hardworking, Sneha ma'am, really. We cannot be forgotten anytime.
Thank you so much, my dear. Thank you, all of you, for your love.
Best wishes, ma'am. Thank you so
Thank you,
much.
Dr. Monica Gupta.
Dolly, thank you.
Thank you, Dolly, ma'am.
Thank you, Dr. Monica. Bye.
Thank you.
Here we
Thank
have
you.
Monica
Thank you all.
Q.
Bye.
Here we have Monica
We
Q.
have 3 Monicas here.
Yes, Monica Q.
1, 2, 3.
Yeah.
Chalo.
Bye, everybody. Thank you so much.
Shatabdi. Bye, Shatabdi. Bye.
Ma'am, bye, ma'am. Thank you.
Bye. Hi, Shatabdi. Hi, and
Hi,
bye.
ma'am. Bye, bye.
Bye, Shatabdi. Bye-bye. Thank
Bye,
you so
ma'am.
much,
Thank
dear.
you so much, ma'am.
Thank you.
Wish you all
Thank
the best, ma'am. Wish you all
Thank
the
you. Thank
best.
you so much, dear. Thank you.
Best
Bye-bye.
wishes, Neha, ma'am. Best wishes always.
And when you are coming to Alwar?
That is 17, 18.
Of May.
6, yes, May.
They were saying you are coming on 2nd of April and something happened.
Yeah, lots of overlap, no? For me, it is fully planned. But then the pharma says some date which actually I don't have free, and now I have blocked it, Alwar and Jaipur. Okay?
And you can cover Bharatpur and Rewari also along with
That
it.
I have told them, but then the pharma is saying only 2 places because only 2 places by road. If you plan out, I can reach to Bharatpur also.
And Bharatpur is only 2.5, 3 hours run from Alwar.
Yeah, but the
Rewari is 2 hours run from Alwar.
Yeah, but they don't have the program that time, no? If you can coordinate for me, the pharma says that we have only Alwar and Jaipur.
Ma'am, because they are doing their work in their area. They don't want, because Haryana is a different state. Though it is only 2 hours run from our place, or 45 minutes from the train by the train.
Oh,
Only
it is
45 minutes by train.
Oh, got it. It is Haryana.
It's Haryana.
Bharatpur.
Bharatpur is Rajasthan.
Haan.
But might be they are not willing to do there.
It's a small society. Something you were saying, not the permission is not available as of now. So maybe next time he will get the permission.
I can ask to them. You are coming on 17th and 18th.
Yes.
So I will ask them if they can arrange for a local sponsor for you.
Yeah, that would be great if you can do that. That's what I'm saying. If you can coordinate for me, I would just like to come and meet them at least, maybe a short CME, because I'll be traveling from there only, not to Jaipur.
No, Jaipur is different. They are into the triangle.
Okay. But then I think we can cover this. After Alwar, we can cover Bharatpur. It is very close by, right? So if possible, please try.
Dr. Monica, you are president right now in Alwar?
No,
You're this
I
year.
was past president.
Okay. So, so President Secretary, please you forward me the number, Monica.
I have got a full list of Rajasthan president and secretary made
Yeah,
by me.
I will message you after the webinar.
Acha, the updated list, no, Monica?
Yes, ma'am.
I will send to everyone. To Dr. Archana also.
Thank you, dear. Thank you so much, Monica.
Sure.
Please share with us, Monica.
Okay. Yes, ma'am.
Thank you.
Definitely.
Bye.
Good night.
Keep rocking. Keep rocking, Monica. We want to see you here. We want to see you here with us. Okay.
No, ma'am, I am with you. I am just standing besides you.
No, that is
You are in the front foot,
you
we are
are
in the
close to
back
my
foot.
heart. You're close to my heart. But I want you to be there, like in the here up in the Foxy organization. Okay.
Yes.
I know I told you you will get the award. Now I'm telling you you'll come forward as chairperson. Next time we are waiting for you. Okay.
Sure. Okay, ma'am. Thank you, ma'am. Thank you.
Bye-bye.
Okay, Dr. Monica, good night.
Okay, bye. Good night.
I will message you for the list.
No, I will. I'm definitely going to give you.
Thank
Right
you.
now,
Thank
I'm
you so
sending
much,
you.
dear. Thank you, dear. Thank you. Bye-bye. Bye. Bye.